My topic, we'll get right into it, is tracheoinnominate fistula. And I say, this is the boy that cried wolf. Everybody knows this story, right? Aesop's fable. Shepherd boy on the hill, he gets bored, says, the wolf's coming, the villagers come, there's no wolf, he laughs, and then they don't believe him. So tracheal bleeding, we see a lot of it, that's the boy. Tracheoinnominate fistula is the wolf, and it really is a wolf. And you feel like that because every time you call for tracheal bleeding, you have to think of tracheoinnominate fistula. But hopefully we're going to go through and sort it out so you don't feel like you're crying wolf all the time. So I'm going to go through the background, the anatomy, the etiology, diagnosis and management, and then a summary. So tracheostomy is a pretty common procedure. It's about 100,000 are done annually. About a quarter of the patients in the ICU will require a trach, and it's pretty low complication rate. Minor issues, usually they don't have much problem, they're easily fixable. Patients in our ICU is cancer patients, particularly head and neck, lung we see a lot of. Neurologic patients, which we see a lot more of, whether you have stroke, hemorrhage, non-hemorrhagic, intracranial hemorrhage, aneurysm, subarachnoid. Many of these patients need trachs and it's to assist in long-term ventilation support while they get better. A lot of our sepsis, ARDS patients, and of course our trauma patients. So it's pretty rare. TIFs are actually infrequently seen. The rate, it's probably actually decreasing the incidence. It's 0.1 to 1%, but in reality, when you really look at the literature, it's like 0.3 to 0.7. So you rarely see it. However, when you do see it, and if you don't act immediately, these people all die. They all die. So you have to have a high index of suspicion. And it's absolutely the worst case scenario. Everybody feels terrible when you've had one or seen one, because it's an infrequent complication. It's deadly if you don't know what to do in minutes, and it's preventable. We put a trach in, this is iatrogenically induced, and these people do not survive. So how can we do better? So I want to go over the anatomy. And one of the reasons why I chose this talk is because during my fellowship, I saw an unusual amount. I saw 5 while in training. So, and I'll tell you a little bit more about those 5. And I was 3 for 5. 3 of the patients survived and actually did okay. The other 2 did not. So with a fistula, how it develops, it's a communication between the trachea and the innominate artery, and it's also known as the brachiocephalic artery. And here you can see the innominate is the first branch off of the aortic arch. So it's got a lot of pressure behind it, and it splits to form the right carotid and the right subclavian. It'll supply blood to the right arm, the right neck, and head, so it's kind of important. And then I'm going to show you some more pictures, but it runs across the trachea. It traverses it for about 3 or 4 centimeters, and then it kind of dives right behind the right sternoclavicular joint. And you really need to know that for later on. So, just want you to get an idea of the skeletal structure. I added in the trachea and the lungs, and then I isolated out the tracheal rings, because you really need to see where you're at when you're doing this. And the optimal place for a trach is between the 2nd and 3rd cartilaginous rings. They place it. That's ideal. Doesn't always happen that way, but that's the ideal thing. This, I highlighted the manubrium of the sternum, because underneath it, and I added the vasculature in, you'll see, there it is. First branch off of the aortic arch is the innominate. You see how it traverses over. It's right there. Then I added in the veins. So you can say, oh, it's obvious. You can see it, right? So I'll do a little bit more close-up. Take it away, get to see. All right, there's a lot of vasculature in the neck. It's amazing there's not more bleeding, right? Well, then you add the muscles in, and then imagine a trach. And if you have a tracheoinnominate fistula and it's bleeding, you can see how sometimes you get lost and you can't find it. So how does it happen? The etiology, there's 3 pictures here. The first, and it's actually, this is the least common, is a direct injury by the artery, by the elbow of the concave surface of the cannula. You can see the cannula just comes over, and this usually occurs from a low-lying trach or a high-riding innominate, and the cannula will erode in and cause an ulceration, and then you get artery, and then you get rupture. The most common way it occurs, probably 70% of the time, is B and C. You have a tracheostomy that is placed correctly between the second and third space, but the tip or the cuff just happens to perfectly align in that area. And for reasons that I'll explain, patients that are at risk, an ulceration happens, erosion, and you get communication through and a fistula forms. So who are the patients that are at risk? We never see any of these patients in our ICU, right? Cancer patients, head and neck, anybody that's had radiation therapy. It's even worse if you have concomitant chemotherapy and radiation. Nobody's on steroids in the ICU. Nobody has high cuff pressures because they have leaks. Mucosal trauma can be for multiple reasons. Frequently you see it with neurologic patients or agitated patients. We don't have any of those in the ICU, moving their head about. Anybody that's required a lower tracheal incision or a high riding innominate, if they've been on prolonged intubation, poor nutrition, or recurrent hypotensive episodes, which interferes with the blood flow to the mucosa. So how do you diagnose it? Bleeding. It happens. You'll get a call. The nurse will call you, and while she's on the phone, she's going to tell you the patient's bleeding from the trach, from the stoma, from the mouth, all of the above. It may be a little, it may be a lot. She may be alarmed, she may not be, or he. But there's 3 questions you need to ask while you're en route going to see the patient. If anybody calls you for tracheal bleeding, please go and assess the patient regardless if you think it's nothing or not. So timing is extremely important. So if it happens within 72 hours of a fresh trach, it's not due to a tracheoinnominate fistula. It doesn't have time for the erosion in the fistula to form, even in the worst patient with the most friable mucosa. This is due to the procedure, or there's soft tissue or skin bleeding, or there's inadvertent puncture of a vein, or the patient's heparin was restarted and now they're bleeding, platelet dysfunction, renal dysfunction. However, if it's 3 days to 6 weeks, you have to think of a TIF. And 70% occur within the first 2 to 3 weeks after a fresh trach. So you're most likely going to see these patients in the hospital, in the ICU, in an intermediate care unit. You have to think of it. So, but what else could it be? If pulmonary artery rupture also can happen, thoracic aneurysm, vasculopath patients, they could have another fistulous tract from another vascular source. So there are other sources, but this is the most deadly. If it's more than 6 weeks, it's unlikely. It's rare to be a TIF, but it can be. It has occurred. It's most likely reported in patients that have had surgery on their trachea, reconstruction, laser therapy, neuromuscular disorders. They have spinal hardware or orthopedic hardware, cervical hardware. You really have to know their history. So the 3 things is timing. Who placed the trach? Because you're going to want to contact that service, whether it's ENT, interventional pulmonary, or trauma service. And it doesn't matter if it was done open or percutaneous. The incidence has not been shown to increase with percutaneous trach. It actually may be decreasing. And if they're on anything for anticoagulation, you have to know if they have a coagulopathy, because that's helpful while you're en route, because you might want to tell the nurse just to shut off the heparin while they're bleeding out from their trach. It's a good idea. So 2 ways it presents. Small bleeding, 50% present with a small hurled bleed before they have massive hemostasis. And this is important, because if you go there and you see and you suspect someone has a tracheostomy that's 2 weeks old and you can't rule this out, you can call the service that did it, go over it. You can either get a bronchoscopy and then a CTA. So is a bronchoscopy really helpful in identifying the tracheoinnominate fistula? Unlikely. You're unlikely to see it unless you have a very experienced person and it's pretty obvious. But it will tell you if there's another source of bleeding, like if they have diffuse alveolar hemorrhage, if they have a tumor, or you can identify something else in the airways to exclude a TIF. And the CTA, will that help? No, rarely angiography, it doesn't help. Even when you have one, it doesn't help at all. But what it does help is it helps in the proximity of where is the innominate artery in relation to your trach. So there was an interesting study done by Sung, and they looked retrospectively at about 24 patients, and they did 3D reconstruction, and they really looked at where was the innominate artery in relation to the trach and the tracheostomy. And they found many of the patients, they had a patient that had a tracheonominate fistula, and their innominate was riding, as you can see in the second picture, it was riding directly over it. They didn't see any extravasation of contrast, they didn't identify it. The only time that you look in the literature is if someone's actively bleeding is if you do angiography of the innominate artery and you're actually in there. So you have to have a high index of suspicion. So this can help you gather your information, but you have to recognize with the small bleed comes a catastrophe afterwards. So 50% present with a small bleed, the other half present with massive hemorrhage. So let me see if I can, if it will. So I make light of this, but if you've ever been involved and seen one, this is kind of what it looks like, because there's blood everywhere, and it's very scary, and people kind of get lost in the forest. So the one thing I really want to make a point of is you have to stop the bleeding. People get caught up in the airway, but these patients don't die from hemorrhagic shock or bleeding, but you do have to stop it because they die of asphyxiation. They drowned in their own blood because the lungs, that blood just goes straight down in their lungs. They brady down, they get hypoxic, and you have cardiac arrest. And that's usually how all these patients are dying. And when you show up and look at this, this is what you see. You have a cardiac arrest going on. There's a lot of people in the room. There's blood everywhere, but no one's controlling. No one's got hemostasis because you're not sure what to do. And there's two things you really can do to try and help save these patients. One is overinflate the cuff. And if you have a good respiratory therapist, hopefully they've already done that. Now, it seems contraindicated in every other situation, but this is when you have to fill the tracheostomy cuff to the max. It works in 80% of the cases. So, this is from Dr. Kenji Inaba. He's out at LA, USC Trauma Medical Center, and I got these from him.
Your resident was very quick, and they overinflated the cuff, and you can see that it was very effective. There's still a little bit of bleeding that's coming up from that trach, but even when you suction down, the blood is not running down into the airway, and it's really holding things steady. So this was a great first move.
So that's a tracheonominate fistula. Overinflate the cuff. It stops the bleeding, but you can still, it's just a very tenuous situation. And this, obviously they had help, and the gentleman you can see is intubated from above, but he still has his tracheostomy in place, and that's what's tamponading. So what happens when that doesn't work? Here's a pictorial. This is the first case. The first one is A, if you overinflate the cuff and you tamponade, it buys you time to go immediately to the OR. You can call your trauma team and get them off, and hopefully they can go methodically and save this patient. The other maneuver is put your finger in there, and it works. This works for 90% of the cases. So does anybody know who this is? Right, Chase Utley. So why do I have Chase Utley up here? Because this is the Utley maneuver. Not after Chase, but J.R. Utley. He described this in 1972. So basically you take your finger, and it looks really easy here, right? You take your finger, you go through the stoma or the incision, and you just hook the innominate, and it's right where the manubrium is. And you just pull up and compress it. So this was a patient that I had. When I was a fellow, I was a second-year fellow in Chicago, and we used to moonlight at a hospital that basically was an LTAC, and it had all ventilators. And so that's probably why I saw a larger amount of tracheonominate fistulas than the average bear. And I got called by the nurse, and the patient was bleeding out of his stoma. He had a 2-week-old trach, and the respiratory therapist had already inflated the cuff, overinflated it, and it was still oozing about. And so I have tiny hands, size 6 gloves. So the blood was just oozing out, and I got totally lucky. I just went, oh my, and put my hand in and pulled up, and it stopped. Great. Now what do I do? So I'm still ventilating this guy through his tracheostomy with the overinflated cuff, and my hand is also in there, and I'm stuck. So what do you do, right? So I called trauma at Cook County, and I just happened to get Dr. Barrett, who was the chief. And so he's talking to me, and I explained to him the situation, and he says, okay, great, patient needs a Foley. And I'm thinking I'm talking to a madman. I'm like, a Foley? I'm like, okay. I'm not arguing with him. This is a chief of trauma. He really knows what he's doing. So I said, okay, the patient already has a Foley. He goes, has a Foley? I said, yes. He's like, is the balloon inflated with air or saline? And I said, turn to the nurse, and the nurse tells me saline. And I said, saline. And he goes, wow, really? Okay. Well, all right, let's go through. And he says, is it clamped? And I said, clamped? And then a light bulb went off. And I said, no, it's draining urine. There's dead silence on the other side. And he goes into a fit of laughter, and he says, okay. He goes, do you have any surgical training? And I said, no, I am a pulmonary critical care fellow. And he was like, okay, I'm going to walk you through this. Trust me. I was like, I have no choice. I am stuck. And so what we did was kind of harrowing, and thank God I was naive and had no idea what I was doing, and he walked me through it, and I will show you what we did.
Right now, or if I remove it, you can see how much bleeding there is because we've removed the tracheostomy. You really just need to slip the fingers underneath, and it may take you a while to find that sweet spot, but you're going to just hold pressure up against the sternum, and that bleeding will stop. Now, if that is possible and it works, but you only have yourself and you need to move the patient, something that you can do to help free your hands up is to use a Foley catheter, like we talked about this morning. Now, sometimes that Foley catheter is just going to pop out like this. If that happens, not to worry, get your fingers back in there and try again. Sometimes you will need to close the skin a little bit so that that balloon stays in place. But you can go again, and that balloon goes deep as you can into that cavity. And what it's doing is it's sitting in a pocket in front of the trachea, but behind the sternum, and it's going to bleed through that hole where the urine normally comes out. So you've got to clamp that off, or all the blood's going to keep running out. And then you want to blow it up. And we were in a bit of a pinch, so you can see we're using air, but ideally you want to use normal saline. And once that's done, you can see that it really can effectively hold that bleeding. It's pulsating there. You can see where it's being moved by that innominate.
So that's what I was walked through, and actually did that, and it was terrifying, but it worked. And we actually transported a patient like this. When I think about it, it was probably insane, but Dr. Barrett was like, oh no, we'll be fine. The gentleman made it there, he got it ligated and did fine. So in summary, when you have stomal bleeding and it's 48 hours to 4 weeks, please think of a TIF. 50% will present with a sentinel bleed. You can get a bronchoscopy and CTA, but remember, half of them, there's many case reports that they rupture during this workup. If you have the acute bleed nightmare, control the bleeding. There will be a lot of people, call the cavalry, but try and stop the bleeding. Just remember, control the bleeding. Overinflate the cuff 80% of the time, Utley maneuver 90% of the time. The ET tube, you're going to need help. You're going to need anesthesia, trauma. Call them early, get your surgical intervention. And that's it.
All right, thank you. Thank you so much, Dawn. All right, we're going to bring up our next speaker while we change out.
Thank you so much.
I'm so glad you came.
Yeah, I was going to wear the...
You
Are you up next?
Yeah.
Oh, cool. I didn't use any of your thunder.
You're all good. I'm so glad you're here. Neck breather? So if I just use the trackpad, I'll be good. So this is advanced.
Turned on? Your mic's turned on?
Yep.
All right, our next speaker. All right, our next speaker is a doctor who almost needs no introduction. She is an emergency medicine doc and a critical care doc, and in most circles that's considered a resuscitationist. And she's truly an amazing doctor. Her name is Dr. Emily Demuth, and she is from Cooper. Please, a warm round of applause.
All right, so as Dr. Mallemat's neighbor, I'm entitled to tell you it was actually his birthday yesterday. So make sure you give him a birthday hug later. He might kill me. But so I'm going to take the baton from my office mate, actually, Dr. Kennedy Little, and talk about the non-bleeding tracheostomy emergencies. And what I want to present to you today is really an algorithm, so a systematic approach you can use in any patient with a tracheostomy who's having an airway complication. And this is an algorithm we teach our fellows here at Cooper, and also is published and part of the European guideline for the management of tracheostomy patients. So first I want to take you back to a case that I had as a fellow here at Cooper. And unfortunately, it was a young man who overdosed on heroin in the field, and he was found by EMS with a syringe in his antecubital fossa, was in respiratory arrest, had a PEA arrest prolonged, and unfortunately suffered anoxic brain damage, and his family elected to undergo trach. And I met him in our step-down ICU, and I got called to see him. As you can see his vital signs, he's hypoxic, he's tachypnic, he's tachycardic, and he's hypertensive. And there's a lot of stress in these scenarios, right? So what I want you to think about, and we will return to this case at the end of the talk, I want you to think about how you would approach this patient. And what I'm going to give to you is a systematic algorithm you can utilize in patients like this. So as Dr. Kennedy Little said, 110,000 trachs in the US annually. We do a lot more trachs than our international counterparts, and most of these are for provision of prolonged mechanical ventilation. Most patients, or half of patients, will have a complication with their trach. Usually it's within a week, usually minor, and the patient survives. However, 1% of them will have a catastrophic airway complication, and half of those deaths are due to dislodgement of the trach, obstruction of the trach, or decannulation. We've seen this picture. We know that tracheostomies are placed usually between the second and third tracheal rings. These are perc trachs that are done at the bedside in our ICUs. The lower we go, the more we risk these bleeding complications, as we just discussed. The higher you go, there's a risk of a laryngeal injury. I want to spend a moment to talk about equipment, because I think lack of familiarity with equipment can really contribute to the angst in managing these patients. And I encourage you, number one, to figure out what brand of tracheostomy do you stock at your institution, particularly in your code cart and your difficult airway carts. Here at Cooper, we use a couple of brands. Most often we use Shiley tracheostomy tubes. We also have Bavonas and some other brands. This is a Shiley trach. I have no financial disclosures. The outer cannula pictured here at the top, you may not be able to see in the back row. There is actually a cuff here, but even if you can't see that, you know this is a cuff trach because there's a pilot balloon. So keep that in mind. In order to have a circuit, give positive pressure without a leak, you're going to need a cuff. So this is the quickest way to figure that out. This structure right here along the outer cannula is your neck plate. Your neck plate gives you all the information you need to know about the size of that trach. We'll talk more about that. This is the inner cannula. Why do these manufacturers make an inner cannula? Well, when we place a trach, we're now bypassing the normal humidification of the nose and the mouth. So secretions get dried, and they can very commonly obstruct the tracheostomy tube. So this allows you to have a disposable inner cannula that you can pop out, clean out, and place a new one. This structure right here is an obturator. When you're placing a new trach, the reason trach tubes have an obturator, unlike an endotracheal tube stylet, it actually protrudes out the bottom of the trach. Why is that? Well, trach tubes are very rigid. If you've ever run your finger across that opening of the outer cannula, it's sharp. The posterior wall of the trachea is a membranous structure. So the reason we place this is to sort of blunt that insertion and prevent damage to that posterior wall of the trach. So here's a couple other brands you may see. Again, just driving home the point that in order to ventilate without a leak, you can't use any of these devices. You're going to actually need a cuff trach. The other thing that I meant to say about the inner cannula, this is extremely important. For most trach brands, and I know for Shiley's, you cannot attach a bag valve mask to give positive pressure without the inner cannula in place. So just keep that in mind. I once had a patient come to the ED who was cyanotic and she had actually pulled out her inner cannula. You need to have that in place in order to bag the patient. All right, so what do you need to know? So let's go back to that room with our patient. He's in our step-down unit 9 days after tracheostomy. He's hypoxic, he's tachypnic. In 2 seconds, you can figure out 2 of these pieces of information. Walk up to him, look at the neck plate. You can see here in the upper right-hand corner, it says 6 DCT. That means disposable cannula tube. You don't need to worry about that. It just means there's an inner cannula. The 6 is the size. It's the distance from the inner diameter, from the inner wall to inner wall. Here it says ID 6.4. We round that to a size 6. You don't need to worry about this outer diameter. So he's got a size 6. We know that. Is it cuffed or uncuffed? Again, the quickest way to know, look for that pilot balloon. Now we know the first 2 pieces. You may not know these next 2 pieces of information. If you can get this information, it's important. The reason we'd like to know the reason for the trach going in is if there's an obstructing supraglottic tumor, it would be nice to know that. If this patient does not have a larynx because it's been excised, we would like to know that because that affects how we manage them. And then finally, we'd like to know the date of placement. And the reason for that is a trach, or a stoma, is simply a tracheocutaneous fistula. It takes time for that to mature, around 7 to 10 days. If you're inserting a tracheostomy tube without a guide catheter in shorter than this time window, you may increase the risk that you're going to have a false passage. So a false passage is where you insert that trach through the skin opening, but rather than going into the tracheal lumen, you end up in the subcutaneous tissue. This can be a life-threatening situation. Why is that? Because if you then bag that patient with positive pressure, unlike Talia's picture, this man is actually not morbidly obese. This is all air in the periorbital region, around his face, under his neck, into the chest. It's all the way down the flanks. He has bilateral tension pneumothoraces. So picture is worth 1,000 words. If you encounter resistance when you're bagging a patient, you have to ask yourself, am I in a false passage? Because this can make palpable landmarks just totally obscured, and it's going to be difficult to both intubate or the stoma or the mouth of that patient. All right, so let's get to the algorithm. There's actually 2 algorithms, but it's the same algorithm with the last step being different. And the only difference is here that the red algorithm we use for patients that don't have a larynx, and the green algorithm we use for everybody else. So I'm going to talk about the majority of the patients you'll see have a larynx. They have a patent upper airway that connects to their lungs. So we walk in the room, we see the patient I described, and just like the A and ABCs, we know we need to oxygenate that patient. So if the patient has an inadequate respiratory effort, we're going to bag the patient. Here's where it's different than your standard patient. The default action of all patients with tracheostomy tubes when you are ventilating them with positive pressure is to ventilate both the mouth and nose as well as the trach tube, so above and below. Why is that? Because we don't know where our trach is and whether it's occluded or dislodged. So emergency action, we want to ventilate both. The next step is then, common things being common, is to remove that inner cannula. You might just be plugged with secretions. You can either clean it off. The manufacturer says you should put a new one in, but if you don't have one, remember you need that inner cannula to bag the patient. So we've checked our inner cannula. If they're still not better, we put that back in. Now the next step is actually both diagnostic and therapeutic. So we insert a suction catheter. If you can't insert that more than a couple centimeters, then your trach is either dislodged or obstructed. Sometimes you can insert it all the way, get a big mucus plug, and now your patient is better. But if either you can't advance it or the patient's not better, the next step is actually to deflate that cuff. And you might be thinking, wait, to ventilate without a leak, I need an cuff inflated. But what I will show you is that a dislodged tube with an inflated cuff sometimes can actually obstruct the tracheal lumen. And now you have the lumen of the outer cannula pushed up against that membranous wall of the trachea, and you're not effectively ventilating because it's obstructed. So by deflating that cuff, you can then reposition your tracheostomy tube, and your patient may improve. If not, the next step is to remove that trach tube. And this is where, if you've never used this algorithm, you may feel uncomfortable, right? Because in our mind, we're just hoping that that's a definitive airway in the right spot. But what I would counter to you is in the face of a deteriorating patient, Further attempts at ventilating and oxygenating through a potentially dislodged or obstructed trach is of no benefit to your patient, and as we saw with that subacute emphysema patient, potentially major harm. So now our trach is out, and we're in emergency oxygenation mode. We're bagging, you might need 2 airway teams for this. We're bagging the mouth and nose, and then how do we get a seal around the stoma? 2 options for this. If you're somewhere where they treat pediatric patients, like in the ED, you can use a pediatric bag valve mask. The second option being something that everybody probably has in their airway cart, an LMA. So just by inflating that cuff on the LMA, you can seal around that stoma and bag the stoma using an adult bag valve mask. So now we're emergency oxygenating and ventilating, and we got to establish a definitive airway, right? So one option is we can intubate the stoma, either with a 5 or 6 ET tube or a trach tube. Or if we're unable to intubate the stoma, we can intubate the green algorithm patients from above. And in an emergency, if you're not able to get a trach tube in that stoma, the next step would be then to intubate the patient just as we normally would. And you're just going to insert that endotracheal tube below the level of the stoma. You can cover this up with Vaseline gauze. You're not going to have a leak because it's a closed system. One word on this, though, either at the onset of this encounter or after you stabilize the patient, you should call your consultant who placed this. Within 12 hours, the stoma will close by 50%, and within 24 hours, it'll close by 90%. They can go down the line, revise the trach, but you really have this narrow time window to get something in that to reestablish that trach to keep that stoma open. All right, so let's talk about the patients we fear, the laryngectomy patient. Fortunately, this is only about 3 to 5% of trach patients, so about 1 in 20 or 1 in 30 patients will not have a larynx. How does that change what we do? Well, unlike the normal anatomy where the mouth is connected to the trachea and to the lungs, now you have the oropharynx terminating in the esophagus, and the trachea has actually been pulled through, and you have the surgically created permanent stoma. One clue that you have a laryngectomy patient is that oftentimes they actually don't have an airway in situ, but they may. And so you have to be aware that this is, again, why the default action is to oxygenate from above and below. So just know that if you've had a laryngectomy, you can't intubate that patient from above. They're obligate neck breathers. So how is the algorithm different? Honestly, it's about the same. You're still going to oxygenate from above and below. And they may not have a tube in place. If not, you would jump down to here, passing your catheter, and then you get to here. Again, we talked about using the LMA, so we're bagging positive pressure, oxygenating both from above and below. And then here's where it's different. This is why it's the red algorithm. I did a reddish box here. You've only got one option. You need to intubate that stoma. You can either use an endotracheal tube or a trach tube of the same size or one size smaller. And this is why it's so important. If you walk around your ICU or your step-down ICU, all these patients should have a backup trach at the bedside just in case their trach gets occluded or dislodged. All right, so let's go back to our patient. We're in the room with him. He's tachypnic. He has increased work of breathing. And so now that we've discussed this algorithm, what's going to be your first step? I think I'm hearing whispering. So we're going to oxygenate him, right? We bag the patient just like we normally would. Default action, both the face as well as his trach tube. What do we know just by looking at him? We know he's got a cuffed tube. If we glance up here, I can tell you it's a size 6. So he's got a cuffed tracheostomy tube, which is a size 6. And the nurse tells you this was placed for anoxic brain injury for prolonged mechanical ventilation and is 9 days old. So now we're ventilating from above and below, but he's just really not getting better. So what's the next step? Intercannula, right? Most common thing that can obstruct the tube. So we're going to pop out that intercannula. In this case, it actually looks clean. There's nothing there. We have to put that back in order to be able to bag the patient. So he's still not better. So what's our next step? Pass the suction. Good, you guys are great. So pass that suction catheter. In this case, you're able to pass it with no resistance. You do a suction maneuver, really don't get much secretion, so that's not the problem. He's still not better. What's the next step? Deflate the cuff. Very good. So we deflate the cuff. We try to reposition that trach tube. We reinflate the cuff. We're bagging him. Still not doing better. What's the next step? I think I heard it. Remove the trach tube. Okay, so now we're doing emergency oxygenation. We're bagging our stoma. We're bagging his face. And now we're going to intubate him. In this case, we were able to pass a trach, the Shiley cuff trach, into his stoma, and now he's improving. We've inflated it, and he's improving. Now, we don't really know what happened, and so I would argue to you that we fixed him even though we don't know what was wrong, right? But one thing that to keep in mind is that you can get a lot of information when you come in to the room before you pop him off to bag valve mass ventilate, and you can get some information from your waveform graphics. So up here we've got pressure and flow here in liters per minute and volume. I'm just going to play that one more time. Anyone notice anything? Our fellows aren't allowed to answer. So if we look at our volume tracing here, and I'm going to show you a still shot. So you've got your inspiratory limb and your expiratory limb, and we're not returning to baseline before the next breath. What's going on there? Why would that happen? Where's Steve Cacciardi? I thought I saw you. What's going on here, Steve? A leak. Good. So a leak. So we have to run the circuit. How big is that leak? It's a big leak. It's half the tidal volume, 250 cc's. So it's somewhere either in the ventilator circuitry, which you can run your circuitry, or it's in the patient, could be in the trach tube, or maybe he's got a huge blowing pneumothorax. But there's a significant leak here. In this case, it was a cuff rupture. This isn't my daughter. My husband's here. It certainly could be. Of our 3 kids, I can tell you this is the universal response to a ruptured balloon. And may in fact be your response. So in this case, I sort of left this out. We did figure out ahead of time that this was a leak. So just keep in mind your ventilator graphics can give you information. But if you use that algorithm, you're going to be able to troubleshoot any problem. So relax. You're an intensivist or whatever specialty you are, you do airway. Trach patients are merely patients with 2 airways. Unless they've had a laryngectomy, then they only have 1. Think about the algorithm, exchanging your tube for a cuff tube if you need to get positive pressure ventilation, using a guide catheter or fiber optics to guide it in to make sure you don't have a false passage, and always have a backup trach at the bedside. Thank you very much.
So hopefully you're getting a whole bunch of talks that are giving you some pearls for your next clinical shift. These are scary situations, but you know, as intensivists and emergency medicine docs, we have to be able to react to all these situations. So while you hope that none of these situations happen, we have to be ready to manage them when they do pop up. Speaking of situations where it can be difficult to manage patients, how many of you have seen a patient with a pulmonary embolism? Yeah, no, I know. You've all seen patients with pulmonary embolism. But the thing is that sometimes when these people are really sick, you might feel all alone in making a decision for this person. And our next speaker, Dr. Michael Benninghoff from Christiana, will talk to us about is maybe it's better that we get a few people involved in this. Maybe it's better that these decisions are made better as a team. So please give a welcome to Dr. Michael Benninghoff.
Thank you very much, Haney. Honor to be here. And we're going to talk about and this is going to be much duller than the last 3 ladies' talks. I have to tell you, this is going to be kind of boring physiology compared to airway bleeding and emergency procedures. But I find it interesting. So this is a paradigm that you'll hear more about, that centers like Cooper and Christiana across the country are developing these PERT teams, because there's a lot that's unknown about actually how to take care of people that are relatively stable but not really stable. So let's get started with a case. 62-year-old male, 5-day history of dyspnea and orthopnea after returning from a trip. Blood pressure stable on physical exam, little tachycardic, a little hypoxemic, neck veins distended, no murmurs, lungs are clear, and his lower extremities are normal. And you find on the CAT scan, some pretty impressive clot burden there, almost a saddle, but certainly the left main pulmonary artery and below that probably segmental and subsegmental clot burden. And the echo shows that the RV to LV ratio is certainly greater than 1. So this is a not uncommon scenario. So anyone recognize this, this story from Homer's Odyssey? The boat's got some problems. There's a 7-headed monster there and a whirlpool. So what does Odysseus do? I mean, he's going to have a few of his men picked off if he decides not to veer left in this picture. But if he veers left in this picture, they all die. So dramatic analogy for what we face sometimes with these PEs. When they're really massive, you all know what to do. You give systemic TPA. Massive meaning what? Shock, significant hypoxemia. But when they're okay, quote unquote, with a normal blood pressure, we're often faced with this discussion about what to do. And we know how serious the condition is. We know how prevalent the condition is. And we also know that patients who have a relatively large clot burden, even if their blood pressure is okay, if they just go home on systemic anticoagulation, perhaps they'll have an increased prevalence of pulmonary hypertension from that, maybe 4%. They'll have perhaps a need for oxygen 6 months later. Perhaps they'll need some help with getting around and doing simple ADLs and shopping. So we oftentimes have trouble quantifying the risk in these patients. These pulmonary embolism response teams, which is what I'm going to get to here a little bit, are evolving because I think we all got tired of operating out of silos. So pulmonary critical care, ED, hospice, interventional radiology. I mean, 5 years ago, we kind of just did our thing. Whoever got called first did what they thought was best. The database is evolving a little bit. We know that the venous column is a column, and clot in the leg may mean ultimately that you're going to develop clot in the chest. So the ultimate end stage for these patients is right heart failure and death. And this is a vicious spiral that we see all the time on the floors, step-down units, and ICUs for our medical patients with PE. But you all know how hard it is to take care of a patient when the right heart's failing. So we prefer to prevent this spiral from occurring. How do we do that? Well, is systemic anticoagulation the answer, or should be something else added to the regimen? We're not sure. And each patient should be taken differently, needless to say, on a case-by-case basis. You can appreciate in the gray box that that's that submassive category, but not all submasses are created equally. And you can appreciate the mortality curve rising to the right side and up based on clot burden, perhaps comorbidities and cardiopulmonary status. So this is if you're the fellows, residents, and anyone else interested in the room, this is really a great article, guideline, Constantides Group, European Heart Journal. This is the massive and submassive algorithm. On the left side, the high risk are pretty obvious. Reperfusion with TPA systemic. Usually that's a no-brainer, like I said before. But in the middle are intermediate high and intermediate low risk. And the debate's really about what to do with these intermediate high risk patients, because we've all seen plenty of them go on to deteriorate further and need TPA, full dose, 100 milligrams. But what do you do when they hit the door and they're intermediate high risk from the get-go is the question. Nobody knows, and there's plenty of people. I've given this talk 10 times at centers like Cooper, and there's plenty of purists that say, well, you can't give TPA to a patient with submassive. I've also seen folks deteriorate that have high clot burden and get worse that then require rescue salvage therapy, and that gets a little ugly. So, some literature to base the formulation of this PERT consortium so that you can understand where I'm coming from. This is a New England Journal article, Pytho, approximately 5 years ago now, looked at 1,000 patients with RV dysfunction, positive troponin, suggesting myocardial subnecrosis with normal blood pressure, heparin versus TPA and heparin, and you can appreciate the Kaplan-Meier curves are relatively the same for mortality. What we learned from this is that even in follow-up, and this is a follow-up study done 3 years later, that the mortality didn't change. What we learned is that, of course, there's an increased bleeding risk in patients with submassive PE when given full-dose TPA. No one's debating that at all. But if you look at the hemodynamic deterioration in patients who received full-dose TPA, they did a little bit better. So in 2014, Jay Geary, who's now at Penn, who was at MGH with Michael Jaff, their cardiologist, they looked at a meta-analysis and decided that looking at 16 studies, I believe, in JAMA, the number needed to treat perhaps in patients that were in intermediate high risk, not intermediate low risk, they perhaps could benefit from some form of TPA. It was a meta-analysis, so take what you want out of it. Then Moppet came along. This is a half-dose TPA, same patient population, plus systemic anticoagulation versus just systemic anticoagulation, and there were no major bleeds. So the patients who received the half-dose TPA had better pulmonary artery pressures in a short time of follow-up. Again, this is all kind of hypothesis generating, and what does this lead to? Well, we joined at Christiana 3 years ago a PERT consortium that was developed at MGH, and the reason that all these centers kind of got together to do this was because we're not sure what to do with these intermediate high-risk patients. And with the advent of real serious use of ECMO for these patients, and embolectomy and pulmonary artery balloon valvuloplasty and suction catheters, the interventional radiologists or cardiologists or vascular specialists, these centers have a lot of tools at their fingertips. So we went up there because we were tired of operating out of silos, and we decided that we'd put together a group in our healthcare system, just like Cooper's size healthcare system with a lot of specialists around, interested in patient-centered care and a collaborative effort instead of operating out of silos. So we went up there because it was a labor of love. We were kind of all talking about how to treat submassive, high-risk, intermediate PEs on our own, but we figured we'd put our heads together, join the consortium, and see what came of it. So the algorithm we designed for our healthcare system was this algorithm here, and it's based a lot on the simplified PESI score, which is in the box on the left side. But in order to attack this problem uniformly and remove variability from the practice, we mandated that certain things be performed, such as like guaranteed diagnosis of PE, and then other things before they would call this PERT alert. Those PERT teams are popping up, and there's got to be a way for us to communicate effectively. So we needed to have the diagnosis with high clot burden, so RV to LV ratio greater than 1, and then they needed to have some other evidence of right ventricular dysfunction, so echo evidence of it, or troponin and BNP being positive, suggesting necrosis, or clinical instability as defined by the simplified PESI score. So we set out for this 1,000-bed healthcare system to put this algorithm into practice, and my group partnered with the ED team as well as vascular intervention with backup from cardiology and cardiothoracic surgery to put together this 24/7 dedicated conference line so we can have this consultation in real time. So if you can imagine, the patient in the case that we discussed hits the door, ED doc does the analysis, does the workup. This looks like it's a submassive, perhaps intermediate risk PE. They put out the PERT alert. Then we, in real time, get on the phone and discuss this case. It's pretty amazing. At MGH, 7 doctors get on the phone to talk about a PE in a patient who's on 2 liters. I'm like, that's incredible dedication if you think about that. But we've dedicated ourselves to a collaborative effort where 3 of us are involved. And again, this is what's really important, I guess, for residents as well as the takeaway. That we're not here to debate if the patient's troponin and BNP are normal, that should be anything more than systemic anticoagulation, but perhaps if those things are abnormal and the RV's bad on the echo, that something more than just Lovenox or the DOAX or whatever you're using is warranted. So we set out to educate everybody in the healthcare system, and after 2 years, we saw about 239 PERT alerts. And our a priori hypothesis was just we're going to communicate better. That's it. We told the administrators, support us, put together the template, invest money and resources required to track the data And we're just going to talk better as clinicians. That's all we're promising to you, is we're going to get on the phone and have real-time consultations and be patient-centric and remove the silos. But what came of it was comparing the pre and post, so calendar year 16 and 17 is pre and post. You can follow along the chart here. We were really blown away initially when we looked at our data. This is Vizient, UHC Vizient data based on coding, so it's not perfect, but it's something to sort of follow. The early death rate was really high. 2.5% was kind of worrisome. Mortality index was greater than 1. You all know that's bad if it's greater than 1. So by simply putting a new program into place, nothing else changed. We cut the mortality down to, by 30%, and the early death rate went down by half. So I always say, we go to these PERT talks. I'm a pulmonary intensivist. I don't do any procedures that are kind of like fun cath lab type of procedures. So I don't have anything to gain from this other than what's best for my patients. Currently, as we speak, we're up to 330 cases. What's interesting, and what we learned from Emory and MGH along the way, was as the healthcare system gets better about communicating about PEs, you're going to have more people talking about PEs. So now the hospitalists, now the residents, I have a couple of residents with me here that work on this research with us. Now everyone's talking about PEs in just a short period of time. 11% of these PERT alerts are called on the floors. And then to make sure that we're still doing what we set out to do, we just confirmed in calendar year 18 that we stayed at the benchmarks that we had improved upon for the most part in terms of early death, mortality index, and length of stay, all indicators that are really important when you're talking about bed flow and throughput, and by the way, the patients are doing just fine. And this is our data. This is a subset of patients that got cath-directed lytic therapy. You can appreciate pre-PERT alert in 16 versus PERT alert in 17 post, that for some reason, and this is not stuff that we really set out to prove, this came up as a pleasant surprise, that after the PERT alert went into place, just by communicating, again, I just kind of keep reiterating, all we do is talk about what we're going to do for the patient. If they go to the cath lab, that's great, but 3 doctors are trying to figure out what's best. But we cut down on ICU utilization and ICU length of stay just because of the new process. And I don't think, it comes up a lot. How do you explain it? I don't know. But it's not by chance, because we didn't change anything else, and we cut our ICU utilization dramatically. So just one quick thing, because I have pulmonologists in my group that say, just put a midline in them and give them 50 a TPA. Now, what I've been convinced by the interventional radiologist is, if you can appreciate on the right side, the TPA would go systemically, and there's kind of like this vortex that forms, and you can't really get into the clot. What the IR guys tell me is they think that this works better because they actually get into the clot with the catheter and inject it directly into the clot. So that's one of the things that come up oftentimes when the non-interventional guys say this is driven by interventionalists. So yeah, I get it. I understand the point, but the physiology may be something here. So I'm going to skip over. There's a bunch of cath-directed lytic therapy studies that have come out that are kind of like works in progress and again, hypothesis-driven. The Ultima trial was the first one, and the bottom line is all these, Seattle 2 was a bigger version of Ultima with a little bit higher bleeding rate, but all these are cath-directed lytic cases on patients with submassive PE that are intermediate high risk that showed that, and this isn't a surprise, that RV pressures get better and the need for oxygen gets better slowly. The perfect registry, if you want to read more about this, is out of Stanford. They looked at their first 100 cases of cath-directed cases in submassive PE and found, again, pulmonary artery pressures get better. The problem with these retrospective reviews is it's not long-term follow-up, and we haven't proven there's mortality benefit. In our own institution, over 6 years, we've learned a lot about what dose of cath-directed therapy, TPA, locally is necessary, and we think we've got it down to 24 hours, 24 milligrams. So if you have debates with your teams here about how much to give, 50, 100, I don't know. I kind of think that less is more when you're talking about systemic TPA or cath-directed TPA, and another trial, Optilice, looked at 4 milligrams versus 6 milligrams versus 12 milligrams in the cath lab. And so the bottom line is everyone's just really trying to figure out how to make the patient less dyspneic, how to ensure that their vital signs are improving, and it doesn't hurt if the pulmonary pressures go down. Now, I can't tell you that this translates to less dyspnea in 6 months or a better 6-minute walk test in 6 months, but one of the reasons we got together, put our heads together and joined the PERC consortium was so that we could learn from other institutions about what they're doing. So if you can imagine 80 of the quote-unquote leading centers are sending in their data to determine whether or not it's worth it to do cath-directed lytic therapy, like front line for these patients when they hit the door, is the question that's being asked. And I think it's a fair academic debate. What we know that this PERC consortium idea works because we enhance communication. I don't know anything else other than that, other than if they're massive PE, you give TPA. If they're low risk, you give systemic anticoagulation. And in between, you have to kind of like look at all the parameters, use your PESI score, look at the echo, determine if they have subendocardial necrosis, and consider if you have cooperative partners in the vascular interventional radiology or cardiology space, consider if the patient's dyspneic. Let's face it, if Haney's an active, fit young guy, and he comes in and he can't move out of his bed without being dyspneic, and his heart rate's 110. That's the kind of case that you really ask your interventional radiologist. Perhaps this guy should get 24 milligrams locally at TPA versus just sit and wait. So that's the idea behind the PERC consortium. It's patient-centric. It's case by case. But I think that we're going to learn more, and I think we'll learn more soon as data pours into the large database in Boston. Thank you very much.
What a morning, huh? So we're going to take a break right now. It is 10:10, and we're going to break till 10:30, and we're going to get started right at 10:30. So we're going to have all of you step outside. There's some more in the multi-purpose room. There's some snacks that you can grab, but just grab them, hang out in the lobby, see our sponsors, and get right back here at 10:30 because we're starting promptly. One other announcement I want to make is that the security has told us that people are parking at the medical school, and unfortunately there's no parking at the medical school. So if you parked your car there, you may want to go relocate it. See you soon.
Oh, it's on here. Oh, okay.
Yeah. You can unplug this for now, right?
Haney, great talk, man.
Thank you so much.
Yeah, nice
to
to
see
meet you. Yeah, you have gained some weight and grown a beard,
Thanks, I think.
but you look smarter.
Okay.
Great
Thanks.
job again.
All right.
What's up, brother?
What's up, brother? How you doing?
Good.
Good.
I know you're busy. Just wanted to make sure. So, setting up my computer, is it okay if I just plug in somewhere?
Yeah, you'll plug in here. It's what you have the new Mac?
Yeah.
Lightning. Okay, perfect. So you just plug this in. You'll be good to go. Sure. All right, Dr. Porter, you are. Where's your talk?
There should only be 2 talks on there.
The only issue is that if this is from a PC, we don't have the software to load the talk to access the security file.
What do you mean if it's from a PC?
Well, I think I know what's going on here. Do you normally use a PC?
You mean versus a Mac?
Mm-hmm.
I hate Apple.
Well, unfortunately, to access the file off this flash drive, we need a PC to unlock the file to pull it up. So can we put it on this computer? All right, we'll figure it out. And then I'll get another flash drive so that we can, do you know what I'm talking about? His is password protected with the software.
And the software won't open on your computer?
Yeah, so it's an exe file. So if we could put the talk on this talk, and then I'll put on another flash drive over here. We'll get it working. You got your talk?
Yeah. Well, Cooper won't let you put something on the flash drive unless it's protected. Sure.
All right.
It's moving, eh?
It'll come up on the back too.
What's that?
It said it's moving.
It's moving. Where's yours?
Real quick.
What was yours again? The name of your
FYRDS, go down. Save
T ECMO?
it. No, that's my. Sorry, I have my computer, so if it's not on here, I still have it off, so it's fine. Go under ECMO talks.
We can password in.
It's not on here.
You could have done it. It's the simplest password in the world.
I'll try and save it on here again and get it there.
Okay, no problem. Yeah, there you go.
Just so you don't have to spend time.
Sure, no problem. Okay.
Chuck Dennis from St. Luke's.
Pleasure.
Nice to meet you.
Do you have your talk?
I have my flash drive ready.
Ribs.
I emailed them to you last night. I have the backup.
Let me just check.
Just want to make sure it's working and everything.
What was the name of your talk? I'm sorry, everything's swimming around right
It's
now.
long-term complications of ARDS.
Okay, good.
I'm gonna eject this and give it back to you now.
Okay. I don't know where the top went. Oh, I see the top.
You got it over here. Here's the little thing. Hey, you gotta put this on a drive or something?
Yeah, I'll grab you a drive in 1 sec.
You want like I was just gonna say a Google Drive or something like that.
No, I will flash drive. This way we put on this. Is it gonna load though on this computer, or it's password protected?
Well, it depends too. Is your flash drive set up?
This one?
Yep.
Very nice. Great. Wait, let me grab one and we'll test it out.
Yeah, I'll wait for you. I can even email it to you or something.
Yeah, I have an extra flash drive, so we should be good with that. All right, there you go. There you go.
Thanks so much.
I'll be right back again. Thanks.
No problem.
All right. So what was that talk?
It's this one right here.
Let's see where that flash drive is.
Fits like a glove.
Where would I grab it?
Looks like it took.
Flash drive? Yeah, there's a port up here too.
Oh, okay. Well,
Also,
to
it's
access.
formatted for Mac. It's not gonna.
Right, that's what I was.
Is it exFAT?
Oh, extra like he used to be.
Yeah. Like you're an X on your injury.
Oh, is it going to show on the other monitor?
check this out.
In a range.
Yeah, it's showing on the other monitor.
Good. No, it's weird.
I'm pretty sure that's what it does. Yeah.
Shit. If you change it to scaled, I
Right.
think it'll show you the resolutions.
Totally.
Yeah, try that.
That's 4x3.
I know that's still going to be for
Yeah, but at least we're in the thousands.
Yeah.
I mean, I honestly still don't think it's going to work. Also, it's
4x3, like I said.
All right, let's
4x3 the other way.
Hang on.
It's not a 16
If we use the
ratio.
HDMI, we can still record out of the projector. So why don't
Yeah,
we switch this to
we'll try that.
HDMI? Okay.
All right, good. So his opened up now.
What's wrong with it looking like that?
It doesn't work on the recorder most likely. That was good. You want to try it?
Do you have your flash drive, Dr. Port?
It just scales to whatever resolution
Try it
you
the other way.
No, you
That's
can
not the
make
issue
sure
we're
that you got it
having,
back.
though. The issue is that the
And we're
recorder
good. We got you loaded
only
up.
takes certain resolutions, and we're not entirely sure which resolution that is.
And this
This
mic
is
is working?
default by 1920.
Yes, if you want to actually get mic'd
Right, I'll
up.
talk
Okay, folks, we're going to get started as people trickle on back in. We are going at a frenetic pace today, but that's mostly to make sure we get everyone up here and give everyone the time to speak. Anyone going to the afternoon workshops today? Show of hands. Awesome. We have an airway workshop, which is sold out, and an ultrasound workshop, which is sold out. I wish I could say if you want to come last minute, but we have no spots left. So next year, if you're interested, get registered early. These are really popular workshops, and the airway thing is just amazing, pig tracheas and all sorts of techniques. So the next person I want to bring up is one of our famed surgeons here, Dr. John Porter. I had the pleasure of having dinner with him and to learn that the man is multidimensional, and I won't go into it now, but if you ever have the opportunity to have dinner or some coffee with the man and learn more about him, truly fascinating person. But what he's going to talk to us about today is rib fractures, whether or not they should be plated, kind of controversial hot topic maybe these days. So please give the man a warm welcome.
Is this mic working? Well, thank you for the introduction. I can't stand behind the podium. It's too restrictive, and I like to tell stories, and I like to move around, and Chris Rock, when he talks, he moves around, so it works for me. So I want to start off with a little story just to wake you up after the break, because it's so damn dark in here. That's not swearing, by the way, so you can't put that on the evaluation that I used a bad word. So I train in the martial arts, and I train with samurai swords. And I just want to tell you a story about the Emperor of Japan who lost his chief samurai. And he decided that he went to HR, and they said you had to have diversity. So he had applications throughout the world for a samurai. And there was 3 people. Japanese samurai, Chinese samurai, and a Jewish samurai. So the first thing you've learned from my lecture is that there were Jewish samurai. You can write that down. So the Japanese samurai walks into the room, bows to the emperor. Emperor opens up his hand, and a fly comes out. Japanese samurai takes his sword out. 2 pieces of fly, no more buzzing. Walks out. Chinese samurai walks in, same thing, bows to the emperor. Emperor opens up his hand, the fly comes out. Chinese samurai, 2 cuts, 4 pieces of fly, walks out. Jewish samurai walks in, same thing, bows to the emperor. Emperor opens up his hand, flies buzzing, takes out his sword, 1 cut, fly still buzzing. Emperor says, what kind of samurai are you? You didn't even kill the fly. Jewish samurai said, circumcision, not meant to kill. So it has nothing to do with rib fractures. But it's my favorite story. It works better when I have the sword in my hand, but for some reason security always stops me when I have my sword. So we're going to talk about rib fractures. To plate or not to plate, that is the question. You saw my other titles on there. That's my real title, Jedi Master. It's over top of the door in my office. And I don't have any disclosures, but I'm accepting some. If you want to give me some money, I'll put your name on the slide. Email will be at the end. I have Zelle, Venmo, all of those, because I have a daughter that told me what they were. I did not know what they were. So rib fractures are the most commonly injured item in the chest. Very, very common. There's probably somebody in the room who's had rib fractures. If nobody raised their hand, I had 3 from playing football. And the risk of rib fractures increases as you age because of chest wall compliance and osteopenia. In trauma, we see folks that are over the age of 65 just slip off the toilet and have 5 rib fractures, where you have a 12-year-old run into a wall and won't have any rib fractures because their chest wall is more compliant. They don't break the ribs, but as you get older, rib fractures are very common. This stat, although the pointer doesn't work, is that the mortality increases with each rib that's fractured. So if you're over the age of 55 and have 3 ribs that are fractured, what do you think the mortality might be? Somebody said 10%, we'll go with that. Everybody else is shy. It's actually almost 20%. Now imagine if you have a person who's over 65 is going for open heart surgery and the surgeon said the mortality was 20%. You'd probably pick a new surgeon. But rib fractures, that's what the mortality is, and it increases for every rib that's fractured. And you're not dying from the fracture, you're dying from pneumonia. The incidence of pneumonia is as high as 30%. And you know, when a 20-year-old gets pneumonia, they do all right. When a 60-year-old gets pneumonia, a lot of them die. So the mainstay of treatment is pulmonary hygiene. I don't like pulmonary toilet. It sounds nasty. I'd rather do pulmonary hygiene. So if I'm in the hospital, don't order pulmonary toilet because I'll get upset. So pain control and pulmonary hygiene, those are the mainstays of treatment. And we actually have at Cooper, we have a rib fracture pathway. We put the patients on it. They go to the step-down unit or the floor. They get pulmonary hygiene. They get out of bed. They don't get chest physiotherapy because that's cruel and unusual punishment if you have a rib fracture. I actually have a tattoo. I have a list of all the things tattooed on my chest of the things you're not supposed to do if I become a patient. Play country music, chest physiotherapy, if I have rib fractures. But think about the country music for a second. We did a study in Mississippi and found that if we asked the family what music the patient liked and played that music in the room, they required less sedation than if you played music that they didn't like. Imagine being paralyzed chemically, hearing the music that you hate no matter what it is, and not being able to tell anybody to change it. And you wonder why the person's agitated and combative. They just want you to change the station. But I digress. But we have a rib fracture pathway that includes all those things, and we published on that to show that doing that decreases the length of stay and decreases the complications. Now the thing is with rib fractures, you really need a CT scan of the chest with 3D reconstruction if you're even going to consider rib plating. Because you can't look at the chest x-ray and see if the qualifications or the indications are actually met. And so this is a 3D reconstruction. I am not smart enough to make it rotate and put arrows on it. It took me almost 15 minutes just to get this into a PowerPoint slide. I'm just being honest. I was sitting there struggling and saying words I can't say in public. And I said, why do I even need this slide? Well, they're going to ask to see it. I'm talking to myself and stuff. So you can see on the right side of the slide, you can see the rib fractures, and you can see that they're overlapping. To be honest, there was a chest x-ray that went with this, and I was trying to put them together side by side. It didn't work. But if you looked at the chest x-ray, you only saw one rib fracture. But on the CT, you see multiple rib fractures in 2 or more places next to each other. That's a flailed chest. And that's an important thing to remember. Flailed chest becomes one of the indications where rib fracture, where rib plating has been shown to be useful. The other one that has been shown to be useful, you can see that the ribs are overlapping. So it's a bicortical separation of the rib. So if these are the ribs, if you got a little bit of fracture like that, you don't need to do rib plating. If it's overlapping, rib plating may work. So that's why if you're considering rib plating, you need to get a chest CT and ask for reconstructions. Otherwise, you can't make up your decision. Also, depends on where the ribs would be located. Obviously, if they're in the front, they're easy to get to from a surgical point of view because rib plating is screws and plates and drills and stuff like you get at Ace Hardware. So you need room. If you move to the back in the posterior chest, you don't have room to do that. The other thing in the posterior chest, as you start putting those things in, the aorta and the IVC sort of get in the way, and things have gone into those, not at our hospital, thankfully, and the patients don't do well when you put a screw into the aorta. So why would people think that rib plating would work? Because external fixation of the chest, taping, braces, all those things have been shown not to work. They don't decrease the length of stay, they don't decrease the pain meds, and they don't decrease the incidence of pneumonia. So if plating it and restricting the motion from the outside doesn't work, why would it work on the inside? Well, it sort of does on the inside when you select the proper patient. And this just shows you again that you need the chest CT with 3D reconstructions to do the proper patient. Now, you may not be at a trauma center, and you don't have to be at a trauma center. You get a person with a fall, and they have one rib fracture on the chest x-ray, and you're doing pain control and all of that, and you think you're fine. You really need the CT of the chest because you're going to find other rib fractures. And then you'll decide if you need to do plating or not. And so the Eastern Association for the Surgery of Trauma has practice management guidelines, and they've done the most work to determine when and if rib plating is useful. I want to pause for a second just so you understand how important I thought you guys were, because it took me a half an hour to get this from the East guidelines into a PowerPoint slide. I could have taken a spleen out faster than I made this PowerPoint slide. So the questions that they were trying to answer when they did the literature review to come up with the practice management guidelines was, in a flail chest after blunt trauma, should it be performed versus non-operative management to decrease the mortality, decrease the ventilator days, decrease ICU length of stay and hospital length of stay, and pneumonia and pain control? And then the other question is, if it's a non-flail rib fractures, do the same things occur? And then they looked at all the literature to see if you could get an answer to the question. There are some people who will plate one rib. There are other people that will go to Chili's and plate the ribs there because they like rib plating so much. And then other people won't plate the ribs until it's 10 ribs. So the literature is all over the place to try to look at that. So this is what the answer is. In adult patients with flail chests, they only can conditionally recommend, because the data are not that strong, that if there's a flail chest, open reduction internal fixation, which is the rib plating, does decrease all the questions that they ask. Decrease mortality, decrease ventilator days, decrease pain meds, and decrease incidence of pneumonia. So we have a protocol at Cooper Trauma where if there's a flail segment and the ribs are overlapping, we do rib plating. And on our own internal review, it does confirm what the East guidelines say. The other question is that if there's not a flail segment and they're not overlapping, that you're rib plating to increase RVUs and the ability to buy a summer home. But you're not rib plating to decrease mortality or to get the person out of the ICU faster or to get them off the ventilator faster. The other thing is we do this early. You don't have a person that has 5 ribs that are broken, flail, overlapped, and then do the rib plating on day 10. The benefit is to do it early to keep them off the ventilator, or to get them off the ventilator sooner, to avoid the tracheostomy, to decrease the incidence of pneumonia. I'm sure everybody in this room knows that the longer you're on the ventilator each day, the incidence of pneumonia increases. So by day 10, the person probably already has pneumonia, so you've lost the benefit of doing the rib plating. From a technical point of view, you can do it thoracoscopically now. You can do it with a small incision. You can do it without getting into the pleural space. You can do it from within the pleural space. All those things are there, but that really doesn't change the indications. Just because you can do it without getting into the chest and do it minimally invasively doesn't mean you will plate one rib. So, rib plating, yes in flail chest with bicortical overlap, no in all others. And then for the people that live in Philadelphia and wonder why I live in Camden, that is the view I have from my apartment. If you live in Philadelphia, you get to look at my apartment. So thank you very much for your attention. And I have 1 minute and 7 seconds left for questions because this thing is flashing up here.
Actually, we won't take any questions, but I'll tell you, for you, Dr. Porter, no.
Well, I stopped early so there could be questions.
2 reasons why I'm letting you answer questions. First of all, you're a fascinating person. The second is you know how to use a samurai sword. I fear you.
Right.
So
I could also kill you with bare hands right now.
that's okay. I believe you. So any questions from the audience while we get Dr. Dellinger set up?
If there's no questions, I need a volunteer to throw. Oh, there's all those things for pain control are fine. You're doing all those things first, epidural, nerve blocks and whatnot. But remember, if you got an elderly person, and we typically see some people with 10 rib fractures on the same side. That's a lot of nerve blocking to do. It's also kind of hard to get your epidural up high enough to get all of those. But we do pain consults with anesthesia and assess those things first. But once the rib is, see when the bones move, just like if you break your leg, when it's moving, it hurts. You put it in the cast, it's not moving, the pain gets controlled. You can't stop breathing. So, but by plating it, it's not moving, so the pain control is better once you plate it. So again, thank you very much for your attention. Thank you for inviting me. It's been my pleasure.
Thank you, Dr. Porter. Thank you. People ask me often, why'd you go to Cooper? And there are a lot of reasons to come to Cooper for all the amazing things that we're doing. But truly one of the biggest reasons I came to Cooper was to work with some of the legends in critical care. And I'm proud to say that I get to work with one of these legends most days. And his name is Dr. R. Philip Dellinger, who really needs no introduction. But he'll be speaking to us today on APRV in ARDS. A lot of vowels and some consonants in there, but please give him a warm welcome.
Thank you, Haney, and thanks for all the work you've done to put this very fine course together. I have no conflicts of interest for this talk. Let me get a little nostalgic on you before I get into what for many of you will be a very complex lecture that I'm going to really try to simplify. So this is the paper that introduced airway pressure release ventilation to the world, published in 1987. I was a reviewer on this paper. I was also board certified in emergency medicine and not yet certified in critical care because the board exam was going to be given later that year. I was medical director of the Bentob County Hospital Emergency Department in Houston. I had met John Downs because I was getting active in the Society of Critical Care Medicine. He had been president 3 years before this in '84. It was 12 years from when I became president of SCCM, and I didn't know Chris Stock at the time. I got to know her very well. She has had a very prominent career in original science and critical care, becoming the chief of anesthesia and critical care at Northwestern. This study was done in large animals. As most of you know, airway pressure release ventilation is available on most ventilators that we use in the ICU. It goes by a lot of different names, bi-level, bi-vent, duo something. They all have some fashion of two in them. And this is what the pressure over time waveform looks like with APRV. It has a T-high or a pressure time that's a high time, and then it has a T-low, which is the time for a drop in pressure. It has a P-high, T-high, P-low, T-low, no J-low. and it allows spontaneous breathing throughout the cycle, and you'll see that's one of the reasons a lot of people think that APRV might have advantage in ARDS. You can think of this as high continuous positive airway pressure, high CPAP, with occasional releases. The release is when with the pressure drop from the P high to the lower pressure. One of the reasons APRV has been advocated for ARDS is the sustained high pressure that you see may open lung that is very slow to open through mechanisms such as the pores of Kahn. Oops. The other potential benefit of APRV is it does allow spontaneous breathing that occurs mostly on the P high. And the advantage of spontaneous breathing in any patient that is supine or nearly supine is that when you deliver a mechanical ventilator breath, it tends to go to the non-dependent areas of the lung, which is not where you want it to go because the blood flow is going dependent. And if the patient is not spontaneously breathing, you do not get good VQ, ventilation perfusion matching. However, with a spontaneous breath, the diaphragm moves more in the dependent area in the supine patient, and that allows you to get that breath to the more dependent areas of the lung and better match with perfusion. So that's the advantage of spontaneous breathing. The initial APRV settings, P high at either the previous P plateau or the previous mean airway pressure that you had on conventional ventilation as a starting point, T high from 4.5 to 6 seconds, P low at 0 in most cases. The reason you set the low pressure at 0 is that you're going to use a short low pressure time, or short T low, and you want to have high flow, so you can use a short T low to get rid of CO2. But we'll talk a little more on the upcoming slides about the T low and the P low influence CO2 elimination, and they also set your total PEEP. The T low at 0.5 to 0.8 seconds and a release frequency of 10 to 14 cycles per minute. So now let's talk about oxygenation and CO2 removal with APRV. So these are the determinants of oxygenation. Your P high and your T high will determine your mean airway pressure, and APRV is intended to give a high mean airway pressure in order to oxygenate better. The T low and the P low determine your PEEP, and the PEEP also determines your oxygenation in ARDS. And the spontaneous breathing is also an integral component of oxygenation when it is allowed. You do not have to have spontaneous breathing. You can use APRV in a paralyzed patient. CO2 elimination occurs with what we call a dump. When you have expiration, you have a dump out of the circuit and out of the lungs that takes CO2 out of the lungs. CO2 elimination is influenced by the length of your T-low and also by the number of releases you have per minute. So if you choose a T-high, as you lower T-high, you will increase the number of dumps and increase CO2 elimination. The determinants of total or effective PEEP. Your T-low is, the purpose of the T-low, as we just mentioned, is to allow CO2 elimination, but it also sets PEEP. As I mentioned, the P-low is usually set at 0 to give you your highest gradient for expiratory flow during your dump time and facilitate CO2 removal. Your T-low also controls how much auto PEEP you have. And so I want to stop there and make a very important point, which is with APRV in ARDS, your PEEP setting is determined by how long you set your T-low. A shorter T-low gives a higher PEEP, a longer T-low gives a lower PEEP. So when you think of T-low, think of both CO2 elimination and think of setting your total PEEP by how much auto PEEP is generated based on your T-low. So we've been showing pressures over time. I now want to show you some expiratory flow curves over time. This is during the dump. So these are all during the T-low. Here is the start of the T-low when you'll have a very high expiratory flow. Remember that this is 0 flow on the x-axis. This is expiratory flow over time below the x-axis. Let's say you had a P-high set at 28, and you have typically your P-low set at 0. When you have your dump, you'll start out with a real high expiratory flow because the pressure gradient is 28 and 0. And then you'll get a decrease in expiratory flow. And if you keep that, if you set that T-low long enough, you'll go to a no-flow state. Now, going to a no-flow state is a problem because you have all that wet, boggy lung, and you don't want it to go to no flow. You want flow present at the end of the dump, so that's how you create your PEEP. So if you're going to no flow, you're going to a PEEP of 0, or if you had it set at 5, you go to 5, and that's bad because that's going to induce ventilator-induced lung injury. The main criticism or the main issue with airway pressure release ventilation is that your total PEEP or your effective PEEP is determined by how much auto PEEP you have. And you can't measure your auto PEEP directly like you can with conventional ventilator modes. So since you can't measure auto PEEP, you really don't know what your PEEP setting is with APRV. There are some sophisticated modeling where you look at something called time constants. And time constants are what's the decrement in flow that occurs during expiration. And that's determined somewhat by compliance and resistance. And people have attempted to use very sophisticated formulas to get some idea about where you want to set your T-low based on looking at your expiratory flow over time. So let me show you an example. We mentioned earlier that you don't want your expiratory flow to go to zero because that would be pretty catastrophic in your ARDS patient. If you let it go to 50%, that's going to give you a lower PEEP than if you let it drop to 70%. That'll give you a higher PEEP because you'll have more auto PEEP. And if you have it set at zero, your auto PEEP is your total PEEP or your effective PEEP. So the recommendation based on looking at time constant calculations, which are not precise, is to set your T low so that your expiratory flow has dropped to somewhere between 40% and 70% of the peak. There are some large animal studies that even demonstrate that a drop to 75% of the initial in some large studies may decrease or give you optimum decrease in stress and strain. Now that I've shown you some basics, let me spend a few minutes going over some actual graphics of patients that are on APRV. So here's an ARDS patient on APRV. Here is P high, here's your T high, here is your T low, and your P low is 0. So you have a gradient for expiratory flow during the dump of 29 to 0. And if you look at this is pressure over time, this is flow over time, and if you look at your flow over time, here is inspiratory flow, here is expiratory flow. Remember, these lines that go up and down are just flipping back and forth between showing you inspiratory flow above the x-axis and expiratory flow below the x-axis. So if you look at the expiratory flow, here's your initial peak flow, and then here is the end of your T low, and I would say that's about 50%. So that would be a reasonable starting point for your T low. Now, remember that if your oxygenation is still inadequate and you want to increase your PEEP, you would shorten your T low. And that's going to increase your PEEP by increasing your auto PEEP. With ARDS, our goal is typically oxygenation. If you use the ARDSNet low and high PEEP tables, you're setting PEEP to oxygenation. So this would be somewhat similar. You just don't know what the PEEP is. A couple of other things to note on this. Here's volume over time. You can see that the 238, that's your inspired and expired tidal volume. So with your dumps, when you dump, it's going to measure your exhale tidal volume, and then when you go back to P high, it's going to go back to the reinflation point, and there you're going to see your inspiratory volume. This is giving inspiratory and expiratory volumes of 238 or 239. And unless this is an incredibly small patient, these tidal volumes are going to probably be in the range of 4 mLs per kg predicted body weight. So clearly these tidal volumes are actually below the 6 ml per kg recommendation predicted body weight for ARDS. Also, you'll note this PEEP of 6. This is somewhat misleading. This is a measurement, it's an attempt of the ventilator to capture a PEEP reading right at the end of expiration, but it's not, you know it's going to be higher because it's not measuring that additional flow coming out. So this value is relatively not useful. And this is what it looks like with spontaneous breathing. You can see here that with the spontaneous breath, you get a little negative pressure and a little positive pressure, and you generate some flow. You can even use pressure support or automatic tube compensation with APRV, allowing the patient to breathe not just spontaneously, but to breathe with a little pressure support. The weaning method is typically to drop the P high and lengthen the T high, and over time convert it essentially to a CPAP mode, and then switch to spontaneous breathing trials. Limitations of APRV is the spontaneous breathing that occurs on P high is good for oxygenation. It also facilitates CO2 elimination by moving CO2 more proximal in the circuit, but it also increases transpulmonary pressure and increases the risk of ventilator-induced lung injury. Also, since you can't calculate auto PEEP, you don't know what your total PEEP is, and you don't know what your driving pressure is. I wanted to finish and just point to some recent literature. For years and years, when you read about APRV, the evidence base, there really wasn't any human studies, there weren't any randomized controlled trials with APRV. And finally, in 2017, we got our first randomized trial comparing APRV with conventional ventilation out of China and published in Intensive Care Medicine. Enroll patients with PaO2, FiO2 ratios less than 250, mostly pneumonia. There were 71 patients in the airway pressure release ventilation and 67 in the ARDSNet low tidal volume ventilation. And there were rather impressive benefit in the APRV group in this study. There were more ventilator-free days in the APRV. There was more successful extubation, less tracheostomy, and less mortality. Limitations or criticisms of this study, it was single center. There was a high mortality rate in the control. It obviously could not be blinded. And the respiratory therapists were allowed to have sedation protocol in the APRV group. So the conventional ventilation were more wild type, whereas the APRV had a rather meticulous protocol for sedation that were run by the respiratory care practitioners. Last slide, just to mention some contraindications for use of APRV, large bronchopleural fistulas, and severe obstructive lung disease. Wanted to acknowledge a couple of people that if you go on the internet, you'll find some works by David Pitts out of Alabama and Josh Farkas with Pulmonary Critical Care that offers some very useful visuals. Thank you very much.
Wonderful, thank you so much. And while we change out speakers here, any questions from the audience? I did have one question, Dr. Dellinger, and that's the question as to whether or not a patient truly needs to be paralyzed for APRV. Sometimes that comes up, and what are your thoughts on that?
Off still mic. Yeah, I remember a first-year critical care fellow came to me all deflated and said, the consultant just came by and sort of gave me a hard time and said I couldn't use APRV on a paralyzed patient. And so I told him to go take the original large animal study. The original study was done in paralyzed large animals. So if you paralyze your patient, you don't get the spontaneous breathing, and we talked about the benefits of that. You still get the high mean airway pressure, and I didn't have time to go into it, but there are also studies in large animals that suggest there may be an advantage of extrinsic, auto-PEEP. Using auto-PEEP to achieve your PEEP in ARDS may have some advantages over using set PEEP. So there are reasons why you might use it in a paralyzed patient.
Wonderful. All right, another round of applause, please, for Dr. Dellinger. Our next speaker is from Temple. Any Temple folks here? All right, you brought your crew.
I got my crew.
All right. The next talk will be ECMO and ARDS. So when your ventilator strategies fail, what's the next steps? And Dr. Parag Desai is going to talk to us a little bit more about that. Please welcome Dr. Desai.
All right, thanks for having me. It's hard to follow Dr. Dellinger here, but we'll try. No disclosures. We're going to talk about trial data that's pertaining to ECMO use in ARDS, and then understand the utility of ECMO in ARDS. I hope to either convince you that we have enough data to use ECMO, or refute that we have enough data to use ECMO in ARDS, and kind of see where the literature and we as intensivists have to go for. This is always interesting to me, that you look at, this is from ELSO, this is from January 2019. It's going back to like 1990 and looking at the number of centers that perform ECMO. It's interesting that for about 20 years, the level was the same, and then in 2009, everything changed. The biggest impact is that the technology changed. The machines got easier to have, the oxygenator got smaller, there was more percutaneous technology, and then we had the H1N1 epidemic, and then the CESAR trial was also released at the same time that said maybe we should use ECMO. But let's take a closer look. If you just look at the registry outcomes data, and again, this is retrospective review on center-reported data that's fed into a registry, but it gives us a sense of what we're doing. So if you're just pointing out the adult, and I'm going to focus just on the pulmonary, the survival to discharge or transfer for any adult patient on veno-veno ECMO support is 58%. In 2013, it was 53%. In 2016, it was 58%. So technology has changed. The number of centers seems to have quadrupled. The machines have gotten easier to do. The mortality numbers are not really there. Why? We'll see what it is. We've kind of talked about this. I'm not going to belabor this point. You know, mechanical ventilator complications, either causing some biochemical injury and biophysical injury that then leads to multisystem organ failure and also volume-induced lung injury. ECMO is really an offshoot of the cardiopulmonary bypass circuits that used in the operating room. You have a veno-veno configuration, you have a veno-arterial configuration, and you also have an extracorporeal CO2 removal configuration. I'm not going to focus on veno-arterial. There really is not much data on veno-arterial support in ARDS patients per se. There's an ongoing trial right now about extracorporeal CO2 removal in ARDS patients who are going ultra-protective lung ventilation, so we're not going to talk about that. So the configurations, this is a nice cartoon that, you know, the common is you have drainage from the venous, I think this point, yep. You have a drainage catheter that's placed in the venous circuit. You have an infusion catheter that's going into the venous circuit again. So the heart's independent. The patient's hemodynamic physiology is going to depend on what the patient's heart's doing. You're going to drain this blood through a pump. It's going to go through a blender. It's going to get oxygenated, and with countercurrent gas exchange, you're going to get decarboxylation, and it's going to get fed back into the patient. Other configurations could be upper, so you have both in the IJ, and then you have single lumen catheters. If you look at ELSO data, just retrospectively, from a 20-year period from 86 to 2006, there are a couple of things that stand out. There were about 1,500 patients not randomized. VV bypass increased survival compared to VA ECMO. And if you go back to the ELSO registry data I showed, the VA ECMO survival and mortality data is fixed around 48%. And that hasn't changed for 20 years. The median time on ECMO was 7 days. The median patient age was 34 years. 9% of patients sustained radiographic evidence of infarction, neurologic, hemorrhage, or brain death. This is important because this is how the trials were designed, and this is how some of the prospective scores are. Mortality was, of course, associated with increased patient age, pre-ECMO hyperacidosis, increased duration of pre-ECMO ventilation. That 7 days pops up again. Patients with predominantly low BMI, underlying cause of respiratory failure. I think this points to whether or not the respiratory failure is reversible, whether or not there was chronic lung issues present prior to the institution of ECMO, and then complications on ECMO. So relative discharge in this registry was 50%. So how many randomized controlled trials do we actually have that talk about mortality and survival benefits on ECMO? 4. Yet the numbers of ECMO centers have quadrupled. Interesting. The original data is from '79. It was an ECMO trial. This was hard to do, but it's the first one. They used VA ECMO to drive oxygenation in their group. The lung protective strategies weren't really maximized, so there was a high mortality rate. Can't really use this in the current literature. This paper in '94 really used no lung protective ventilation, and they were predominantly doing CO2 removal strategies. And then we're left with the CESAR trial that came out in close to '09, and then the Eolia trial that got published late last year. CESAR has some important points that it brought to us. It was a UK-based trial that essentially said you have multiple centers that will refer patients to a single center to perform their ECMO. One of the criticisms of CESAR is that some patients that were referred to that final center never made it into the ECMO group, yet they survived. And so is it expertise at the center in managing those patients? The other criticism is that there was a protocol change during the trial itself, and then the conventional arm of the control group, there was no control for lung protective strategy. CESAR did show some important points. We'll talk about that in a second. The Eolia trial that came out last year was stopped early because of futility. We'll talk about that some more, but I think it was a very well-run trial overall that showed some important points. So if this is CESAR, it's clearly evident that the ECMO group had better survival compared to the conventional group. The number needed to treat was 6, which is easy. However, the cost is $70,000 per day of ECMO, double the cost of conventional mechanical ventilation, and then $33,000 to the quality of annual live years. In Eolia, there's an 11% reduction in absolute 6-day mortality in groups that got ECMO compared to groups that got conventional mechanical ventilation. Eolia was well designed. The control group had strict protocols as to low tidal volume strategies. It was patients who were heavily prone, patients who had neuromuscular blockade listed early on. However, because we didn't hit the magical 0.05, this is treated as a failure. 28%, 35 patients from the control group crossed over to the ECMO arm. Those patients that crossed over were severely hypoxemic. 9 of those had cardiac arrest. Almost half of them survived. During ECMO, tidal volume reduced by 43%, respiratory rate reduced by 23%, and the PEEP was relatively unchanged. Dr. Gattinoni, who wrote an editorial on this, said there was a 66% reduction applied mechanical power to the lung. By converting these patients to ECMO and then using lung protective strategies and minimizing their tidal volumes, you stop the progression of that lung injury from occurring, maybe leading to an increased survival in that group. However, this is the challenge. There were 64 units that participated. Look at the enrollment numbers, 120 and 120 in each arm. Less than 1 patient per unit per year was enrolled into this trial. Because of this, there's questions of literature saying, let's redo this trial with an N of 622 and put patients into an arm that says I do conventional mechanical ventilation and then in an arm that has ECMO. I personally have a hard time saying that I can withhold ECMO on some patients that are progressing in front of me. It's shown by this high crossover rate. What are the patient characteristics? They were well matched. They were predominantly male. They were equally sick. Look at the PF ratios that they went into both arms. Low, 70. I think it's impressive what Dr. Dellinger showed in the Chinese study. Those patients came into the arm for APRV at a PF ratio of less than 250, right? I always say this is a continuum. A patient comes in, is hypoxic, you think it's ARDS, clock starts. What do we do first? We minimize any further airway injury or ventilator-induced lung injury that we can do. Either use deep sedation or early mechanical ventilation. Then think of proning. It's the next step. So in prone position, 60% of patients in both arms are prone. There is data that has reported data and centers kind of feed back into a survey. Proning is heavily underused in this country. We don't prone enough early enough. And then they had some other maneuvers that they did. I think the last slide that's not showing up there is that almost 90% of the patients in both arms had early neuromuscular blockade on. If you look at a pooled mortality analysis that was just recently published not too long ago for 60 days, looking at both the CESAR trial and the Eolia trial, it favors ECMO. If you look at the 30-day mortality analysis, and this looked at not only the CESAR and the Eolia trial, they included 3 observational studies. And for whatever criticisms we can add for a systemic review that's added some observational data to it, because of a lack of evidence, it still favors ECMO to some degree. What are the adverse events rates for these patients? Not a lot. It's interesting that in the CESAR trial, there was none reported. They had 1 cannulation complication. In all of the other trials, there have been some intracranial hemorrhages, pleural bleeding, and requirements for massive transfusion. But the event rate has been under 5%. So ECMO versus conventional mechanical ventilation, severe ARDS, again, from the same paper. If you look at the treatment failure rate for conventional mechanical ventilation, it was a 42% treatment failure in conventional mechanical ventilation. That's a pretty high number. So the group from Columbia has proposed an algorithm on how to approach ECMO in ARDS patients. And I think it's quite interesting to look at. So they say treat the underlying onset of respiratory distress syndrome. Standard lung protective ventilation strategy, we're talking 6 to 8 cc's per kilogram of predicted body weight. Use of early neuromuscular blockade. Use of prone position ventilation. And then your clock starts on the PF ratio of less than 150. Strongly recommend prone positioning, recommend what we talked about, a high PEEP strategy. Consider vasodilators and maneuvers if you believe in those. And then look at how these patients are monitored. Can you maintain a PF ratio for greater than 6 hours, or is it getting worse? If it's getting less than 80 over 6 hours, continue current management. If it's getting worse, greater than 3 hours, you're going on to an ECMO arm. And if they're getting more hypercarbic. These numbers are driven from the original ELSO registry data. On the other end, if your PF ratio is greater than or equal to 150, but you're not getting, if you're getting worsening acidosis, and there's no contraindication to ECMO, you may want to proceed towards ECMO. I think the Eolia inclusion criteria help kind of guide us on how we should treat our patients. So early mechanical ventilation less than 7 days. Their enrollment criteria were PF ratio is less than 50 for the first 3 hours, PF ratio is less than 80 for the first 6 hours. Acidosis and hypercarbia that was persistent greater than 60 for 6 hours. Look at the minute ventilation rates on these patients, 35. 90% of them were paralyzed and sedated. Maintaining the plateau pressure less than 32, I would argue that we should look at the driving pressure, not only the plateau pressure when looking at these patients. These patients had predominantly high FiO2 ratios and PEEPs that were greater than or equal to 10. The inclusion criteria said prior to randomization to ECMO versus conventional mechanical ventilation, these patients had heavy neuromuscular blocking agents and prone positioning. We always talk about this in our conferences, is what is the effect of early neuromuscular blocking agents on these patients? I think when it comes to a PF ratio of less than 200, less than 150, it's the effect of the end expiratory lung volume that you're concerned about. There's some trauma literature and there's other animal data literature that says increased abdominal work or breathing further increases cytokine release that then potentiates the volume-induced lung injury that we're seeing. So if we can't maintain them, that's where we're using neuromuscular blocking agents. Or deep sedation if you can eliminate the spontaneous breathing. The exclusion criteria is important as well. So for purposes of this trial, it was less than 18, but greater than 7 days of mechanical ventilation. Is that lung disease going to be reversible? I think that's what the point there is. Are there long-term chronic respiratory insufficiencies that were treated with oxygen therapy or non-invasive ventilation? Again, pointing to, is there a reversible condition here? Cardiac failure resulting in VA ECMO, history of heparin-induced thrombocytopenia. There's an ongoing debate about whether or not all ECMO patients need to be anticoagulated, but for purposes of the trial, they were. Cancer expectancy with life expectancy in less than 5 years. Severely ill, coma after cardiac arrest, neurologic injury, and such factors. Once you put a patient on ECMO, you're welcome to go to the REF score. This is kind of developed to kind of get a sense of if I put a patient on ECMO, what is my mortality going to look like once I put the patient on the REF score? It's an interesting tool, not for you to do before you put a patient on ECMO. Please don't do that. It's an interesting exercise to kind of have a patient on ECMO and see what is happening with that patient based on the criteria. Take-home points, I think ECMO provides normalization of gas exchange. We're trying to provide oxygen to the tissues while giving the lungs some rest. It gives us enhancement of proving lung protective strategies that are proven. The lung rest permits to help reduce the mechanical power applied to the injured alveoli. It may attenuate the ventilator-induced lung injury we're seeing. I think these last 2 points are important. Role of expert centers in helping to minimize rates of complications. These trials, CSER was done at a very expert center. Eolia, 64 units, mostly European centers that have a lot of ECMO expertise. That still needs to be teased out some more. And they need to optimize patient management both prior to and after initiation. Prior to points to, are we being strict with our lung protective strategies? Are we being strict with our deep sedation protocols? Are we being strict about proning patients? Which I frankly don't think we do enough of early enough. I think the next speaker is going to talk about the management of at least the ventilator after the initiation. But I leave you with this thought. Dr. Lewis from UCLA Harbor kind of left this in his paper after he did a Bayesian analysis. He says, if you no longer ask does ECMO work, there's evidence that it works. The question that I think we really need to ask is by how much does it work? Are we targeting the correct patient population in who it works? And eventually, what cost are we doing this at? Questions?
Thanks, Dr. Desai. We're going to switch out speakers. Any questions from the audience? We can take one. Okay, our next speaker is a good friend of mine, another really amazing resuscitationist. He does emergency medicine and he does critical care, and he runs a critical care resuscitation unit at the University of Pennsylvania in a city known as Philadelphia. His name is John Greenwood. Please give him a warm welcome.
All right, hello. So my job today is to kind of talk a little bit about the practical approach to mechanical ventilation after you've placed someone on ECMO. So we're going to try to keep it clinical. We're going to take it to the bedside a little bit. We'll kind of interject a little bit of evidence, a little bit of opinion, all in 15 minutes. So let's get started. These are the objectives, and I have no disclosures. So here's the challenge. You, in front of you, have a 42-year-old female who is brought in through the emergency department. She came in saying have 2 to 3 days of worsening shortness of breath, found to have really bad pneumonia. She gets admitted to your ICU. All things are going okay, but she continues to decline, so you decide we're going to intubate this patient and provide lung protective ventilation. Do all the things that we do for any patient with what's on this x-ray, which is ARDS. Over the course of the next day or so, despite your efforts, she becomes more hypoxemic. And we get to that point where we're seeing our oxygen saturations go down, our FiO2 go up, and despite our ARDSNet criteria, we're going to start doing some of the adjunctive things, which include inhaled pulmonary vasodilators, neuromuscular blockade, optimizing our PEEP for driving pressure, and then also we're going to start some proning. But even despite those best efforts, this young woman who's sitting in front of you begins to deteriorate more, to the point where you're left with your back against the wall and trying to decide, what am I going to do next? Now, Dr. Prague, who just spoke about ECMO, VV ECMO as a rescue strategy, it's a great point that at this point we probably need to be considering, if our PF ratio is fairly low, early initiation of VV ECMO. Well, so let's get started. So the patient goes on ECMO, and now you're left with a couple of other questions. Now we've restored the patient's at least systemic oxygenation. Things are looking okay. But then this lady walks in the room and says, this is Sally. This is one of my favorite women that I worked with a few years ago. She's a respiratory therapist, been doing it for 40-something years. She was wonderful, really, really smart. But then she peeks her head in the door and says, okay, doc, what do you want your vent settings to be now? And you're like, well, we're on low tidal volume ventilation. That should be fine, right? And she goes, well, you want to change it, right? And you pause. And you're like, do I? I don't know. Well, these are our goals, Sally. We want a SAT of 88 to 92%. Are we reaching that? Yes. Our PaO2, is that okay? Yes. How about our PCO2? Well, yeah, it is. But do you want me to change the vent settings? Well, how are you going to vent this patient or provide mechanical ventilation for this patient who's on high sedation, probably paralyzed still, and on VV ECMO? Well, let's start with the fact that now this patient has 3 lungs, right? And the patient has the native lungs that are obviously failing, but now they have a new artificial lung. And we can fix a lot of these clinical endpoints with simply management of our artificial lung right now. And so our initial ECMO settings are going to be something around 4 to 5 liters for a normal human being, which ends up being about 60% of our cardiac output. And the reason why we need to titrate our ECMO flow here is because ECMO is not that efficient in oxygenation. It's flow dependent, and we'll touch on that more in a second. But it also depends on the efficiency of this artificial lung. And so this artificial lung is pretty good at delivering oxygen through the oxygenator itself. That's set at 100%. So we now have a reasonable SAT goal, reasonable PaO2. And in order to achieve our PCO2 goal, we just titrate the sweep. Now, fortunately, ECMO takes away CO2 very efficiently, so it's not all that hard to do. So we focus on fixing, or at least addressing, our new lung, but we haven't yet touched upon, again, what Sally's asking you, which is, how do you want me to address and sort of interact with the patient's native lungs? Well, let's separate it out. So that's our oxygen saturation equation, and basically it's fairly simple in the sense that the amount of oxygen that's delivered to the patient is a ratio of how much is going through the native lung, how much oxygen and ventilation is provided by the bad lungs, plus the ratio of oxygen and ventilation that's coming from our artificial lung. And so if we take that into consideration and we say that the flow through our native lungs that's not reaching our ECMO flow at 4 to 5 liters a minute, multiply that by our mixed venous SAT at the end, and the proportion of that that's going through our native lungs is effectively 0. Most of the work is being done by our new lung. So the oxygenation and ventilation things that we're concerned about, maybe they don't really matter at all with our ventilator. But they actually do. Just a little bit. So she's still waiting. She's looking at you and she's like, come on. So Sally was a wonderful person and a wonderfully active smoker, and would always remind me that I have a smoke break in 10 minutes. So if you don't tell me what to do, we're going to have a problem. So at that point, I said, fine, let's just put her on the mechanical ventilation, the low tidal volume ventilation protocol for the ECMO patients, right? Everybody loves a good protocol. Now, I work at University of Pennsylvania. We also love a good protocol, but I can tell you that every protocol that's developed at Penn takes about 2.5 years to actually happen, and so this one's still in the works. So she tells you, you're killing me, we do not have a protocol. What do you want me to send the ventilator for? So I say, well, okay. What we're experiencing here is actually not that uncommon. In fact, this was a study done in 2014 where in over 28 countries, 141 centers were surveyed about what protocol do you use to ventilate your patients who are placed on VV ECMO for ARDS. And pretty much a fraction of these places actually had a protocol. Most of them did in fact use standard ARDSNet recommendations of the lung protective settings of 6 cc's per kilo ideal body weight with a titrated PEEP strategy. So you might be safe in saying that, well, maybe I can just continue on that path. But that's a very small fraction, and oftentimes people have a lot of opinions and beliefs about how we should ventilate patients to achieve our goals. So what if we go through the literature again at maybe some of the better evidence of how to ventilate our patients? If we look at CSER trial, well, what did they do? Well, we just talked a little bit about that in terms of CSER, what they use. They use a pressure control strategy, which really didn't control for tidal volume. So what that means is maybe you weren't actually getting lung protective benefit. But there are some interesting things that they did do. They titrated their ECMO to effectively decrease the patient's requirement for a spontaneous minute ventilation, or at least a ventilator minute ventilation, by increasing up the sweep to get that respiratory rate down to 10. Their tidal volumes were a little bit all over the place, but they kept the pressure controlled somewhere around 20 to 25 millimeters mercury. And then they used a moderate PEEP with a low FiO2. So again, all the work's being done by the ECMO device. But as you'll notice, there's a few trends that actually come out here. We look at Eolia, what did they do? Well, they chose either a volume control or pressure control strategy, but they were much better about limiting the tidal volumes. In fact, their tidal volumes were much lower at 3 to 6 cc's per kilo. And you can do that because one of the biggest problems with low tidal volume ventilation is you get that rise in PCO2. So that can be controlled with your sweep. But one other interesting thing happened in Eolia. They reduced their plateau pressures too, to much lower than what we would consider normal, which is around less than 30. Their frequency might have been a little bit higher, but again, a moderate PEEP, low FiO2 strategy. So this was brought up as well. When I have a question about mechanical ventilation at ARDS, I look to this rock star here, Dr. Luciano Gattinoni, who again points out that probably one of the biggest benefits of placing someone on VV ECMO is we can reduce the amount of invasiveness and the amount of damage that can be done by us using mechanical ventilator. So effectively, we're protecting the lungs even more by reducing the amount of injury. And if you think about this, so I work in a cardiac surgery ICU, we see aortic dissections all the time. What's the analogy here? Well, you're reducing the dPdt of the vent to the lung, the frequency of invasive positive pressure breaths, as well as the stretch that happens with our tidal volumes. So lung rest is the prescription. And so here's a take-home slide before we get into one other thing. So I think overall the best evidence-based strategies for how to titrate your mechanical ventilation for a patient who's already or placed on VV ECMO are to do a couple of things. I think we want to pull down the tidal volumes and the minute ventilation by reducing the respiratory rate, tidal volumes by up-titrating your sweep as much as you need to maintain normocapnia, okay? And in general, what I do try to do is I try to limit the alveolar stretch that can happen even further by make sure my plateau pressures are probably somewhere around 24 rather than the traditional 30. So we have made some changes over the standard prescriptions of what ARDSNet would actually tell us to do. Now I am using a moderate PEEP strategy, so if prior to going on you were on APRV or some other form of high PEEP table strategy mechanical ventilation, I'm pulling that down as well to again limit overdistension. So somewhere between 10 and 14 centimeters of water to at least allow some recruitment, reduce de-recruitment, recognizing that ARDS is a very heterogeneous lung disease, and so I'm trying not to overstretch as much as possible. And then lastly, we didn't talk about this a lot, but reducing our FiO2. So this is a small thing, but maybe important. As we know, with high fractions of FiO2, we can cause some resorption atelectasis in the lung. So we want to pull that down and also maybe limit some local lung toxicity that can occur at high FiO2s. So there's some sort of observational evidence that this exists, and in this patient, we're going to try to do the best we can to reduce further injury. Now, there are two other small pearls. Now, continued proning on VV ECMO is maybe a little bit controversial. However, there is some evidence to suggest that this may also be beneficial, again, to maintain lung recruitment and reduce further injury in non-dependent areas. And this is important. So lung rest in itself does not mean extubation, particularly in patients with acute ARDS. There may be a role in early extubation in patients with acute on chronic lung disease who are awaiting lung transplant, but we've had a few patients transferred to us who have been extubated with acute ARDS, which causes basically full de-recruitment of their lungs, and they basically are apneic by the time they get to us because they have basically 2 concrete blocks in their chest from all the atelectasis. So this does not mean lung rest does not mean early extubation. All right, so we're going to talk in the last 3 minutes, we're going to talk about another clinical challenge here. So you get called to the patient's bedside who was just placed on VV ECMO, you did all your ventilator manipulations, and the nurse comes to you and says, hey doc, we got a problem. This patient's desatting over and over and over again, we're having an issue. So you walk into the room, you look up at the monitor, and this is what you see. Patient's tachycardic, hypertensive, breathing at a rate of 40 spontaneously, so you may need to, already your brain's thinking, what do I need to do to fix this? In the hypoxic patient on VV ECMO, you're thinking about other things too. Obviously, the usual, make sure I don't have a pneumothorax, make sure my oxygenator's working okay, making sure I'm not having any significant recirculation with the device. Did my cannulas move? Is my good lung, the one thing that this patient has going for them, this ECMO circuit, is that all working okay? Things are kind of checking out. But then you're standing there, she becomes more hypertensive, and your SAT's down to 76%. You're like, man, now what am I going to do? I did all these things that I thought were right, but my patient's still hypoxic. You look at the ventilator, still breathing. You can tell lung compliance is horrible. Breathing with a tidal volume somewhere around 200 on these settings, pressure control of 20. Sounds like the respiratory therapist had tried to do some things for you while you're getting to the room because you're in another room. FiO2's up to 90%. You've got some work to do. So what do you do? In this patient who's desatting, now 70%, on VV ECMO, these are your ventilator settings. Do you increase the PEEP, increase the FiO2 to 100%? You're not going to get much marginal gain there. Decrease your minute ventilation or decrease your heart rate. What we have here is actually not a ventilator problem, so I tricked you. This is a mixing problem. So this patient who's in front of you, the ventilator's okay, but what's happening is we're starting to see some of the effects of this patient who was on high-dose narcotics, wearing off on their paralysis. They're starting to wake up a little bit, and they're actually becoming much more hyperdynamic. And remember that equation, the 2 separate sides, the native lung versus the ECMO lung? Well, now we're seeing a lot more blood flow through the patient's native lungs because we haven't increased the flow of our ECMO. So now all that blood flow is a higher proportion is going through those really crappy lungs and not getting oxygenated. So there's a couple ways we can fix that. So some people would describe this as drowning syndrome. Patients are trying to kind of wake up and kind of adjust to this feeling of having really, really poor compliance. First things are simple. Increase your sedation a little bit. Make the patient a little bit more comfortable. If you've titrated down to get a neurostatus, sometimes you'll see this happen in patients who are on longer duration of high sedation therapy. You may even decide, well, we might need to paralyze them intermittently to get their lung mechanics a little bit better and kind of reset a little bit. But then if that fails, you may just want to try to reduce the blood flow through the native lung. And you can do that in a couple different ways. You can drain more out through the ECMO circuit, so increase your flows through your VV ECMO device. And lastly, if that even fails, the patient's even more tachycardic. We see this a lot in the young kids or young adults, the 20-year-olds who are super hyperadrenergic. You may even decide, well, I need to beta block them a little bit to reduce their native cardiac function, and we're going to just run as much as we can through our ECMO device itself. So this was partially a ventilator problem, but you adjusted those things, and sometimes it's actually just the patient's fault, which I like to blame it on the patient every now and then when I can. So with that being said, I'd like to thank you guys for your attention, and if you have any questions, happy to take them.
Thank you, John. We're going to bring up our next speaker. Any questions from the audience?
Yeah. What's your strategy to assume what the native cardiac output is?
I'll just repeat it. What is the strategy to assume the patient's native cardiac output?
Yeah, so great question. So, we do a lot of ultrasounding, so a lot of bedside focused echocardiography to get a VTI. Occasionally, depending on the patient's right ventricular function, they may have a PA catheter as well. But for the most part, for most of our percutaneous VV ECMOs, a quick left ventricular VTI is a reasonable approach for cardiac output estimation.
Okay, thank you so much, John. Our next speaker is one of Cooper's own EM and critical care docs. His name is Dr. Lars Peterson. He is doing one of our short format talks called To the Point, maybe a little bit of a rant, but very informative. So please give him a warm welcome.
So I really don't have a rant. I basically wanted to talk a little bit. I asked Haney, what would just be something practical, particularly for people who are just starting out in their critical care careers. And one of the things I would encourage you guys to do is to sort of develop what pilots might call kind of the walk around, sort of where every day you look in on, well, how is the patient doing? And you do the same things every day. So that way when you see something amiss, you can notice it more easily. So the initial title of my talk was how do I greet the ventilator, but the first thing that I do is I greet the patient. Some of the folks here who are the bedside nurses will know I go up to the patient, I usually hold their hand and I say, hi, my name's Lars, I'm your critical care doctor for today. You're here at Cooper, it's Wednesday morning and you're safe. I provide a statement of identify who the hell I am. I tell them that I give them some orientation, like, hey, you're at Cooper. And I try to give them some degree of reassurance, like things aren't horrible right now, even though it might feel like it. After that, I do turn to the ventilator. This is the ventilator right here. I give it a brief nod. I ask the two gnomes that run the bellows to not cause any problems. I try to assert a little dominance over it. And then I return to the patient. And I look at them and I'm like, well, how relaxed is this person? Is this person too relaxed? Do they have a RAS score of negative 1,000,000? Or is this person clearly asynchronous? This person needs some help to help us keep them safe. So I look at their sedation, and I just sort of get a sense as to is this person overly sedated or adequately sedated or inappropriately not sedated. The next thing I look at is the breathing tube. I just sort of say, hey, is that breathing tube sticking way further out than it was yesterday? Is like the ET tube 4 centimeters at the teeth, which would be a problem. Or do I hear a leak from the breathing tube? Do I get the sense that this patient's losing tidal volumes, in which case now we're out of like flight walk around checklist mode and now into like, well, now I need to emergently evaluate this patient's endotracheal tube. I look to see what the secretions look like, things like that. Then tracing things a little bit further down, I look at the circuit. I want to make sure the circuit isn't held above the patient's head. Every now and again, you see the circuit sort of draining into the patient. That's really good at protecting the gnomes in the ventilator, but it's not very good at protecting the patient from ventilator-associated pneumonia or drowning in their own secretions. So I want to make sure that the circuit looks okay. I want to make sure that there's not so much, humidity and collected water in the circuit that you almost have like this constant bubbling. It's like the circuit has an air leak. Oh no, that's just the tidal volume going back and forth between like a ditch of just saliva. Well, it's not saliva, it's mostly, humidified air. But so we look at that and then we say, okay, the circuit looks okay. So we've gone to the patient, their breathing tube looks okay, the circuit looks okay. And then I turn my attention back to the gnomes and I say, all right, guys, what are you doing for the patient today? I look to make sure that the tidal volume seems appropriate. Now, in a lot of my patients, before I daily round on them, I'll go through and calculate all the tidal volumes. So if I see that tidal volume is above 8 cc's per kilogram, not the ARDS ECMO patient, But if I see that that patient is, their tidal volumes are too high than what I would predict, I would make sure we talk with our respiratory therapist, so I have a little check mark, so like, all right, we gotta adjust the tidal volume there. And then I look at what their peak inspiratory pressure is. Now, a lot of people might be saying, well, we always talk about plateau pressures. Why do you care about what the peak inspiratory pressure is? Well, in a passively ventilated patient, so a patient who's doing pretty well with the ventilator, if they're not ripping huge tidal volumes on a mode that allows them to do so, their peak inspiratory pressure less than 30 would imply that their plateau pressure is less than 30. So I don't have to touch the ventilator. I don't have to do an inspiratory hold. I don't have to do anything like that. My respiratory therapists always get nervous when like they see, you know, our faculty touch the ventilators. There's a really great Gomer blog article about, you know, pulmonary critical care fellow found in trunk of respiratory therapist car after touching ventilator. So I look at that. And then once I've gone sort of through the whole thing, make sure that nothing's alarming, everything looks pretty good. You know, I feel pretty good that I can step out from that patient's room now and go see my next patient and know that they'll be fine until rounds, that nothing needs to be changed until that point in time. If you just take one more thing from this, and maybe it's just out of all that whole list, I want you to start getting into the habit of holding your patient's hand every day. Probably to Sharad's point, you know, our behavior determines a lot about how do we act between ourselves. And I think that reaching out and connecting to your patient, particularly when they're separated from you by sedation or mechanical ventilation or whatever other devices are in them, really helps you connect to that person. And it helps you make sure that you're always going to do the right thing for that person every day. Thanks.
Wonderful. Thank you so much, Lars. Very, very wise words. And I think sometimes we get so wrapped up in what we do and making sure that everything is done for the patient that we sometimes forget that there is a patient. So very wise words from Lars.
I don't have any slides here.
Oh, no slides for Dr. Marianne Charon?
Yeah,
Dr. Marianne,
that was perfect.
that was good?
Perfect.
Oh, good, because she knows I love Montreal, and she's from Montreal. And I'm not saying that
He knows
'cause
curse words.
I know a curse word from Montreal, but we won't go there. Keep it friendly for
Who
the
would
kids.
know it? Is OB here? No.
No, we won't go there.
Or Sebastian.
But you are going to be doing a little bit of a rant today. Is that correct?
A Canadian rant.
A Canadian rant, because the French are so polite. The French Canadians are so polite and nice that I can't imagine you even getting upset about anything at all. So I'm sure this will be very nice.
Best.
All right, thank you.
Thank you. I do have a disclaimer is that I was working last night and I've been up this whole time, so if I have word finding difficulties, I apologize in advance, but I did dress up for you all. So I'd like to take just a few minutes to discuss a therapeutic strategy that I think is underutilized. Those of you who know me probably know what I'm referring to, and that is proning. So let's start this back when I was a fellow, from 2010 to 2012 here at Cooper. I remember we were having a board review session with Dr. Zanotti, and there's a question about proning that came up. And the answer was that, like many other things, proning improves oxygenation, but it doesn't change outcomes, and in fact, it might be associated with more complications. And at the time, that was true. There had been 2 randomized controlled trials, one in acute lung injury in 2001, one in acute hypoxemic respiratory failure in 2004, both for sessions of about 8 hours. Neither found a change in outcomes. Following that, there had been 2 more randomized controlled trials, specifically in patients with ARDS, that were done over longer periods, so 17 to 20 hours of proning. So the first one by Mancebo in 2006 found a trend towards decreased mortality. The second one by the Italian group, including Gattinoni, that was a nice picture. So that group found no change in outcomes, but an increase in complications, such as accidental extubation, more pressure wounds, that sort of stuff. So like I said, these two trials in ARDS were done over over 4 longer proning sessions, so 17 to 20 hours, but they weren't done on low tidal volume ventilation per se. These patients had average tidal volumes of 8 cc's per kg of ideal body weight. So fast forward, I'm an attending, it's my first year. In 2013, the ProSiva trial gets published. So if you're not familiar with it, they looked at proning for 16-hour sessions in patients with what they defined as severe ARDS, or a P to F ratio of less than 150, while on an FiO2 of of at least 0.6, and a PEEP of at least 5. And what they found was a mortality of 32.8% in the patients in the supine group versus 16% in the prone group. And so I thought, this is it. They found the perfect recipe for success. So not only did they select sicker patients with a P to F ratio of less than 150, instead of less than 200 in the other one, in the prior ARDS groups. They proned for relatively long periods, 16 hours, but they also used low tidal volume ventilation, and their average tidal volume was 6 cc's per kg in those patients. So I was all excited and I wanted to start proning. And of course, this was met with a lot of resistance from everybody. So people would say, well, we don't have the right equipment. Well, you don't need any special equipment. You do not need a rotor-prone bed. You don't need special gel cushions or that mirror or face contraption either. In fact, if you go on the New England Journal website and look up the ProSiva trial, you'll find videos of how they did it in the French study. And you'll find that the only equipment they had were 2 bed sheets. So really not that complicated. But then even colleagues would come up to me and say, oh, this patient no longer meets proning criteria because they're getting better now that they're on 16 of PEEP, nitric oxide, and they're paralyzed. And you know, that's not how people were enrolled in the ProSiva trial. They were enrolled based on their initial blood gases. And so I started to suspect that people maybe were just lazy about it. Because it's true, proning is labor intensive, especially at first, but I can assure you that as you start doing it, people get used to it and it gets easier. Because we've known for several years that proning is beneficial, both in human and animal models. It decreases shunting, improves VQ matching, decreases atelectasis by offloading the heart, improves alveolar recruitment while limiting overdistension, decreases ventilator-induced lung injury, improves secretion drainage. And so there's not a lot of therapies or things that we use in medicine that actually have a mortality benefit. So can we please stop making excuses not to use this one?
See, I know her, and that was a rant, but it was the most pleasant rants of all. She was kindly telling us to, like, get our act together. All right. So give me a moment to switch out here. We're going to bring up our next speaker, who's Dr. Jean-Sébastien Rachouin. How was that for pronunciation? All right. I've been practicing my French.
Also French-Canadian, by the way. Right. How's everybody doing? Good? Okay. Yep. This one. Okay. So I assume everybody is super excited about hearing about healthcare policy and healthcare changes and yeah, right? No. I think this talk is pretty important. We're not going to go through all the details about what's going on and how do I advance it? Is that it?
That is it.
That's it? Okay, perfect. So I'm not going to go through every single detail about what's happening, but I just want to talk for a few minutes about what important things you guys are going to see very soon and is going to affect you in a very real way. So, okay, I did something. Okay. So there's no talk that has to do with healthcare finances and landscape without talking about cost of healthcare. We're going to talk a little bit about focus on quality. If you guys have not heard this word BPCI, you should be very familiar with it because it's going to be very, very real for everybody. And we're going to talk about other changes. So every time we talk about healthcare in America, we talk about costs. Costs are high. The curve that shows the costs in red, that's the highest, is the one that is in the United States, is the highest cost for all the developed countries for healthcare. Now, you can read on all the newspapers that we have the worst outcomes in the world. I do not believe that. I do believe that our outcomes, when measured properly, are good. Because mortality is not a good outcome to have healthcare be measured on. Things such as survival after diagnosis of metastatic colon cancer actually is a better measurement of how healthcare performs in America. But in any case, healthcare is very expensive. So, and the increase in cost of healthcare year after year actually is increasing. This is how much healthcare is increasing every year. So even though the last few years it has decreased less than before, it still is higher than it's ever been. Anybody wants to guess why over the last 3 years the healthcare increase has been less? And it's not because of Obamacare. Okay, so it's because there were more and more medications that went off patent and became generic. Therefore, the cost of the medications became less. Therefore, the costs were less. Has probably nothing to do with what we did so far. The current paradigm is, and if anybody has any questions, please stop me, that you have a patient that comes to the hospital and then you get paid for the episode of care. If you did poorly or not poorly, up until now, the paradigm is you get the full payment. What CMS and other agencies want to do is want to shift from that fee-for-service, volume-based payment to a quality-based payment where you're rewarded if you do good things and you're penalized if you do not so good things. So these are the 4 broad categories of payment, with the left being the most volume-based and the right one being the most quality-based. At some point soon, the idea is that they want most of the patients in the country being on a quality-based payment model, so that you will be paid mainly if you do good stuff, not only lots of stuff. So are we there yet? We're kind of there. So we have things that are happening right now that you should know about that are a lot of quality-based things. The goal is to have, at some point, almost every patient be on a quality-based incentive. And right now, at least 50% of the payments have a link to quality in some way, shape, or form. So anybody heard of those things, value-based purchasing, readmission penalties, hacks, MACRAs? Are those familiar terms? Well, if they're not, they should be, because this is all what you're going to be hearing about when it comes to payments, incentives to quality. So the idea for one part of value-based purchasing is that a certain portions of the payments that Medicare does to hospitals is withheld. And then, and that you can see the payments here at 1.5 and 2% per year. And then they score your hospital on various domains. So safety, clinical care, efficiency, and then the HCAHPS, the famous HCAHPS. And they have different weights every year, and those weights matter. And then you get a score. Now, you're scored today on the stuff you did 2 years ago. So whatever changes you make today will impact the scores 2 years from now. So you get a score, and then you either get money back or not. right? And then if 2%, if you feel that this is not a significant number, that's about the margin that most hospitals in America make. So if 2% is your margin and losing 2%, it's not a good situation, right? So where do we come in here? Well, we affect actually pretty much all of this, right? C. diff infections, CAR-Ts, CLABSIs, that's, bread and butter of what we do. Mortality, that's what we do. HCAPS, that's what we do. And Medicare spending, that's what we do. So we impact this in a very real way. And in the not so distant future, I can clearly see that this being on scorecards for physicians, physicians being accountable for those kind of things. Readmissions penalties, so every year Medicare tells us how much we had readmissions. If it's higher or lower than the target, they penalize us. So these are the conditions that are being penalized right now. Some of them are patients that we take care of: COPD, CHF, pneumonia, CABG. The other list are conditions that, if are not documented on admission and do occur, all the payments that come after as a result of this condition, you're not going to be paid for. So hospitals are very much aware of these and are going to be honing in on this. So lots of great things happening as far as quality. But the thing that is becoming a bit changing the paradigm is the BPCI, which stands for Bundle Payments for Care Improvement, which is going to impact you guys very, very soon. So the idea behind BPCI is that the CMS and Medicare, Medicaid do not want to pay anymore for just the hospital, even though quality may be great. They want to pay for everything. Hospital and 90 days after, same way they do for surgeons. Surgeons get paid for the pre-visit, the visit, surgery, and then 90 days after, or 30 days in some instances. So the same thing, that's what they want to do here. They want to say, okay, so intensivist, you're going to take care of a septic patient. We want you to be responsible for the cost from A to Z, and Z includes 90 days after the discharge from the anchor episode. So this started in 2018, and on March 2019, we can either drop in or out of certain bundles. These bundles right now are voluntary, but if you know CMS, you know that this will become mandatory very soon, because some bundles already showed reduction in cost of care, mainly the joint bundles. That's about $800 per patient per episode. If you multiply that by million of patients, that's a lot of money. And the brilliant thing that CMS did is they tax everybody 3% to actually enter the bundle. So they take 3% for the administrative cost, and they won't give it to you back. So how does this work? You can pick right now voluntarily one of 29 patient bundles or 3 outpatient bundles. Again, right now it's voluntary, but soon it's going to be mandatory. Once you pick the bundle, you are responsible for every cost of the patient from the anchor episode until 90 days after discharge. So what does that mean? Well, that means that if we do a poor discharge summary, or we did not do a good transition of care to the outpatient setting or to the hospitalist or to the SNF, and the patient has a readmission or a complication, and they come back and the costs go up, we're going to be penalized. So what the idea here is we have to improve all the things that we are not focusing on right now. So you can imagine that this is a very hot topic. This makes the C-suite very nervous, and they want to focus on this pretty much. So back in September, I was voluntold that I'm the champion for the sepsis bundle for Cooper. And it's been very interesting because I don't know if you know, but how do you know that the patient is septic on admission? Well, everybody says sepsis, pretty easy. We do search criteria and whatnot. Well, it turns out not so simple when it comes to administration. So let's say somebody is septic, and they're septic from a necrotizing fasciitis, and they get surgery. Well, now for their final DRG, they're not more septic. They're actually the highest DRG weight, which is the OR, will trump everything. So you could have entered the patient into the sepsis bundle, did everything right, but at the end they won't count because they're not going to be coded as septic. Does that make sense? If it does, I did not explain it well. Okay. All right, so there's going to be a lot of quality measures into those BPCI bundles as well, and things that they want you to do on those patients. The key thing is that at some point very soon, you're going to be responsible for the SNF the patient goes to, the LTACs the patient goes to, and the transition of care that you give to the hospitalist, and it's going to be very real. We estimated at Cooper we have at risk for just the sepsis bundle about $2 million. So it can go $2 million in our favor or not in our favor, and that can be nerve-wracking. All right. Anybody has any questions about BPCI, guys? No? Okay. Cool. So other changes that are happening in healthcare landscape, projected shortfall of US physicians by 2025 is estimated somewhere between 60 and 90,000. How are we going to handle that? There are a lot of ideas on the table. Telemedicine is a big one, but I think that having APNs and PAs being more involved in intensive care and inpatient setting is going to be the key to being able to deliver the care that we promise to our patients. Other things that are very real right now are most physicians in this country 30 years ago were either private or in public hospitals. Right now, a lot of physicians are becoming employed by hospitals, and the idea is to get all these systems of care in place, economies of scale, and being able to cash in on the quality metrics and being able to get money by controlling exactly what physicians and providers do. Right now, 60% of hospitals are part of a health system, and mergers are occurring at a rapid rate. Mergers will result in, we think, lower costs, economies of scale. You can share specialists, and then you can expand your network, therefore have more bargaining power with insurance companies and CMS. So these are the major changes that I think are happening right now in 2018, 2019. Maybe next year we'll have more changes, but right now this is what I foresee. Any questions, concerns, anything that was not clear enough? All right, so key home take messages. Healthcare is shifting from volume-based to value-based. Quality of care is cornerstone of value-based care and is going to be having a bigger role in the near future. The expanding focus is on the continuum of care, not the episode of care anymore, and then physician shortages and costs will require us having more APNs and possibly a change in the role of the physicians in the near future. All right. Thank you.
Any questions while we bring up Dr. Bendis? Get your slides up. Thank you so much. Probably find it like this guy.
Nope, that's not it. Oh, it looks like it. Yeah, that's it. That's it.
All right, next I'd like to welcome Dr. Charles Bendis, who's from St. Luke's University, and today he'll be talking to us about something that we might not be aware of when the patient leaves the hospital. We high-five when the patient lives, and sometimes we don't know what happens to them when they go away, and it's going to be looking at some of the long-term complications with patients with ARDS. Thank you for speaking.
All right.
Better? I hope everybody could hear me anyway. Pulmonary, where was I? PFTs. So PFTs after ARDS. PFTs generally return to normal or close to normal after 1 year. DLCO is remained a little bit diminished, but vital capacity, total lung capacity, generally almost normalized. At 12 months, when they do ambulatory pulse ox and exercise-induced pulse ox, only 6% of patients actually have hypoxia during exercise. Yet, almost all survivors report decreased exercise tolerance as to where they were pre-morbid. And almost no patients are oxygen dependent at 12 months. So the lungs generally heal. This is one of the earlier studies that ever actually looked at this. This data has been replicated a number of times since then. But most survivors of ARDS, their PFTs generally fall in these ranges above 80% predicted. This is a fun study where this group took just a small number of patients and just followed them for a long time. Chest x-rays and CT scans show resolution of infiltrates, and only 20% of survivors have persistent chest x-ray abnormalities at 1 year. So the lungs tend to heal. What doesn't heal and what's harder are these extrapulmonary complications. So the first thing I want to talk about is weakness and atrophy. All of us who practice in the ICU are aware of the syndromes, critical illness myopathy, polyneuropathy, now kind of under the blanket term ICU-acquired weakness. And we all know that there are risk factors for those, meaning neuromuscular blockades, steroids, prolonged ventilation, malnutrition, all of these kind of things like that. These syndromes, this atrophy, this muscle weakness, this neuropathy persists for actually quite some time. Again, as I mentioned before, decreased exercise tolerance is reported in 88% of ARDS survivors at 1 year after hospital discharge, despite normal PFTs. This is, on the top left, you'll see this is normal skeletal muscle tissue. This is tissue biopsy and staining in the lower left corner of ICU or critical illness myopathy. The myopathy can persist, and there are actually some data showing that ARDS survivors have evidence of myopathy up to 5 years after their critical illness. Okay, so very, very long-term effects. PTSD. So I'm sure some people in the room have heard about this as a consequence of critical illness and ARDS in general. The problem with PTSD, especially in some of the earlier literature, is that PTSD is sort of ill-defined in a lot of the earlier papers, but this data replicates itself time and time again when you actually start reading into it. PTSD, including symptoms of flashbacks, phobias, panic attacks, anxiety, insomnia, nightmares, anticipatory pain or dysphoria, things like that, present in 43% of ARDS survivors at 1 year, 28% at 5 years, and 23% at 8 years. The incidence in the general population is nothing even close to this. Along the same lines, there's other psychiatric comorbidity that goes with ARDS. In this study, they looked at survivors at 36 months. 38% of them had some degree of an anxiety disorder, and 23% had a diagnosis of depression, basically meeting the features of major depressive disorder. To put that into comparison, the incidence of major depressive disorder in the general population is between 6 and 7%, and anxiety is a little more common, meaning about 18 to 19% in any given calendar year. So these incidences are much, much higher in ARDS survivors, and there's significant crossover, particularly with these symptoms and the symptoms of PTSD, and with each other. This is a really interesting study where this group took a number of patients and did long-term follow-up with cognitive testing, so neurobehavioral and cognitive testing. And these are truly impressive numbers. In this study, which was published 2012, and there's been one or two sort of smaller studies more recently, but 55% of patients that made it out of the hospital alive after a diagnosis of ARDS had some degree of long-term cognitive impairment. 13% of those issues with memory, 16% with verbal fluency, and 49%, half of the patients had problems with executive cognitive function. So think about that. That's the stuff that gets you through your day as a human being. as a self-sustaining human being. And half of the people that survive have difficulty with this. As an interesting side note, in this particular study, they found that lower PO2 values were associated with greater executive function deficits, so that the more hypoxemic you were, the greater your deficit in cognitive testing was. And I found that was fascinating. Return to work. Working is normal, right? Going to work, getting up every day, going through your routine is normal. In this one study where they looked at all comers of critical illness, at 1 year of those who were employed, less than half, only 45% had returned to work. And in a subgroup analysis and in some other studies, that number in ARDS survivors is less than 40%. This is probably multifactorial. This probably is honestly related to the last couple slides I showed you, related to the cognitive, psychiatric, and sort of the physical deconditioning that goes along with this. But think about that for a second. You send your patient home, and their family and everyone is thrilled because you did a really good job, but they're just not the same. And that's a realistic thing that happens. And I don't mean to be a downer about this because it's just something that we have to be aware of. The last slide about these statistics I want to show you is this study looked at self-reported quality of life scores from patients, and with areas regarding the extent to which their health limits their physical activity, to which their health limits their work, and their degree of daily energy, survivors up to 2 years out at 6, 12, and 24 months of ARDS report less mobility, less energy, and social isolation at rates less than 70% of what the general population feels. So these symptoms, a lot of what I'm just described to you is not exclusive to ARDS per se. A lot of this is encompassed in all of critical illness. However, the effect seems magnified in ARDS particularly. These three pieces of physical impairment, mental health, and cognitive impairment is now being recognized into this bundled term called PICS, the post-intensive care syndrome. And a lot of work has actually started to be done about this because we want to do a good job and save people's lives when they come to our ICU, but we also want to do a good job returning them to normal and getting them back to their lives the quality way they enjoyed before. So, what can we do to help? So, luckily, as I said before, there's a lot of groups actually working on this. ARDSNet recently has posted some stuff about ARDS survivors and some guidelines to kind of help. SCCM has really taken a lead in a lot of these initiatives, starting with the ABCD bundles that were pushed a few years ago, liberating patients from ICU earlier and intact. ICU Liberation Group is doing a lot of work on this. And then more recently, the Thrive Initiative, which is resources for clinicians, for patient and family support after ICU survivorship. Some things, which is a combination of my own opinion as well as some published data that we can do to help, however. So early mobility. Early mobility in the ICU, we know, prevents or sort of attenuates muscle breakdown, atrophy, weakness, and polyneuropathy. It helps with delirium. It helps get people out of the ICU quicker. It helps move people and get them up and moving and more normal, lessen sedation, etc. Reduce your delirium burden. Delirium is this ever-present just nemesis that we have as ICU doctors, and it seems like everything we do either makes it worse or doesn't help. But anything that you do and can do or know how to do in your practice to help reduce the burden of delirium genuinely helps in the long term. Delirium, even a single incidence of hyperactive delirium, increases your mortality, it increases risk of cognitive deficiencies long term. It's a very bad problem to have, and once you develop it, it's very difficult to break. So anything, if that's throwing away every benzodiazepine in your ICU, do it. If that means a mobility program, if that means whatever that means for your place in your institution, anything you can do to reduce delirium will help. An early ICU liberation. Obviously, we don't want people in our ICUs a minute longer than we have to, but early ICU liberation, attempting to get people out as intact as we can. Another thing that's actually had a lot of success in a lot of centers are post-ICU clinics. When people get discharged from the hospital, they go back to their family care doctors, sometimes with trachs, sometimes with all kinds of weird symptoms that some family doctors, primary care physicians are just not equipped to handle. So post-ICU clinics focusing on areas like PTSD screening, cognitive and psychological impairment, doing neurobehavioral and neurocognitive testing or screening tests, functional testing, both physical functioning as well as, like I was saying before, cognitive testing, and getting them to appropriate professionals for PTSD, for depression, for anxiety, for support groups, for cognitive rehab can be very, very helpful, kind of catching these people and getting them the resources that they need. Also anthropometric testing, looking at malnutrition, muscle wasting, physical therapy, things like that. And also think about things like when a patient leaves the hospital, they go to rehab, they come home, what if they still have their trach? Do they know how to care for their trach? Who follows for their trach? What about their PEG? What about a lot of these things? Who narrows down the polypharmacy that they were on discharged from the hospital after they come out of the ICU, after they go to rehab and the rehab sends them home on Seroquel at night and God else knows what? Who pares that down? So post-ICU clinics, and just as a way to close the loop with patients and their families and say what you're experiencing is normal. What you're experiencing is not unusual for people who lived through what you lived. Okay? So, in summary, we know ARDS is common, dangerous, and a costly illness. Long-term complications of ARDS are pervasive and really affect quality of life long-term for survivors. Extrapulmonary complications of ARDS are not exclusive to ARDS. It is now sort of broadly under this category of PICS, post-ICU syndrome. And many resources at any of those groups that I listed up there before can help you with guidance on how to help survivors. If there's time, I'm happy to take any questions that anybody might have. Thank you so much. I appreciate your time today. Thank you for having me here.
So any questions while we change out speakers? Just click this. Great, thank you so much.
Thank you.
Now I mentioned when I came here to Cooper, there were a lot of great reasons why I came, and one of them was a doctor by the name of Dr. Sergio Zanotti. However, he had the nerve to leave just when I was getting here, and I didn't get the opportunity to work with him, although his legend at Cooper preceded him. But I was lucky enough to have many interactions with him, including a wonderful lunch in Berlin once, which was a great day for me. And I talk to him frequently, and he gives me great advice, and he's really just one of these cerebral doctors that doesn't just know medicine very well, although he really knows medicine well. He knows a lot about everything well, and he's a good person. I'm glad to have him in my life. So
thank you so much.
I'd like to have you welcome Dr. Sergio Zanotti to the stage.
Thank you, thank you. So it's always great to be here. It feels like home. A real pleasure. I want to thank the troopers who have stayed to the bitter end. I seem to be the last thing between either lunch, going home, or workshops, all of which probably are more appealing than hearing to me talk about teams. But we'll talk about something I think is very important, very relevant to what we heard today. So with the exception of the samurai circumcision, I think that every other thing we heard today, you need a team to perform well. And what we'll talk about today is a little bit about teams and how to make teams better. And hopefully you'll go home or back to your ICUs or your EDs with a couple of very, very actionable items that can help you foster better, more effective teams. So what I'm going to do in the next 15 minutes is talk a little bit about the individual versus teams. We'll talk about what makes a team great and look at some data that's available outside of medicine about team performance, and finally give you a couple of tips of what I think are very actionable items that you can take back to your environments to try to make your teams more effective and work better. So I think like every critical care conference, we should start at the coast of Indonesia in the 1930s with Dr. Hugh Smith, who was a very accomplished biologist who was on a scientific expedition and was really treated to one of the wonders of nature for the first time and reported, I mean, at least in science. And he was on a boat on the coast of Indonesia, and all of a sudden, from one of the trees, a lightning, like he describes, of green came out. And after a couple of seconds, the whole forest turned green and then black, green and black in the synchronous kind of rhythm. And he was really perplexed, but eventually he figured out that it was fireflies who were lighting on in synchrony. He came back to the United States, wrote about it, wrote a scientific paper about it, and he was mocked by a scientific community by arguments that went from evolutionary biology. Why would it make sense for a firefly who needs the light to attract mates to work in a team against their own interest? Mathematically, wouldn't be possible. And for many, many years, people thought that he fabricated the tale. Now, 8 decades later, a group of investigators actually in controlled experiments were able to explain what had happened. And what they showed was, in a paper in Science, very well done, that the synchronous, non-randomized lighting up of the fireflies increases their chances of attracting a female mate by 79%. And I think what nature is trying to tell us is that even for your individual success, the real thing that makes a difference is how you work as a team. And I think that we can really try to explore this in other areas, but I think it's a very powerful lesson. Even when you're trying to achieve something individually, it's the team that makes the difference. So let's look at one of our preferred or favorite team members, the CT surgeon. I'm sure all of you have worked with CT surgeons. And I think a lot of our CT surgeons that we've worked with will really believe that their surgical abilities are if not the only determinant of how a patient does after surgery. And this is, I think, a very interesting population that's been studied by a group at the Harvard Business School, where what they did is they took surgeons who worked at more than one hospital. And they specifically looked at the number of procedures that they would do in a specific, let's say, aortic valve replacement. And we all know that the number of procedures associated with better outcomes. And what they found was fascinating. And what they found was that the individual expertise of that surgeon only applies to how it correlates to the expertise of the team that works with him. So those skills are not transferable. So if you've done a phenomenal number of aortic valve replacements and then one hospital you have great outcomes, if you go to a different hospital, you can't transfer those same outcomes. And really, through a series of analysis, they showed that what they called it, the firm specificity versus the individual performance, that the team was much more relevant as an independent factor of outcomes than the individual. So I think that from this, we can start thinking about what are we doing as we train kids, as we prepare people for medicine. From an early age, we are fostering them to be successful from an individual perspective. Everything we do in terms of recognition of grades, GPAs, in terms of tests, MCAT scores, awards, match day, everything is really geared at fostering the individual. And the mentality is that you have to be a great individual in terms of exceeding your achievement in order to be successful. Yet as soon as they get into the real world, they're expected to work in teams. And really, it's about the teams and how do we make teams better. With medical knowledge being available everywhere, it's very difficult for an intensivist to know something medically that nobody else knows. So what's your superpower? It's not knowledge. It's your ability to make the teams around you work better and work more efficiently. So we'll talk a little bit about what makes a great team. But here again, I think we can say that definitely the team will be more important in our patient outcomes than the individual. So how do you pick a great team? So we've all been either picking for a team or being the last ones picked for a basketball game. But what most people will do from early on is look at the individual accomplishments or the individual talents of people and think that they're going to be good for their team. So we assume that if I have a group of 5 very, very bright physicians, my team is going to be great. And over again, what studies have shown is that that might not be true. So let's look at some studies. Any of you have heard about this experiment by Peter Skillman, who's a design engineer, the Marshmallow Challenge? Anybody? Okay. So this is a very simple experiment that was designed to evaluate teams. And the idea is that you give teams of 4 15 minutes, and they have the following materials: 1 marshmallow, 20 sticks of spaghetti, 1 meter of tape, and 1 meter of string. And the task is very simple. You have to build the highest freestanding structure with a marshmallow on the top. And they've replicated this experiment all over the world. And I'll show some of the results. So they did this at Harvard, at MIT, at Berkeley, University of Tokyo. I mean, a lot of, houses, of very, very high learning. And what you can see consistently, the MBA students were the worst, right? They, on average, had a height of 10 inches. The lawyers somehow got a little bit better and were at 15, maybe it's the extra year of school, right, over an MBA. CEOs a little bit better, but there was one group that consistently outperformed every single group that was tested, except for engineers. We're not going to go there, but every test, there was one group that consistently outperformed them. Anyone want to venture a guess? Recent kindergarten graduates, right? So they consistently did better than the CEOs, the lawyers, and the MBAs. And the question is why? The first assumption is that when you have CEOs, lawyers, MBAs, is that because their individual intelligence or accomplishments are very high, they're going to take care of any task very, very well. Yet what they noted in this experiment is that the MBAs, for example, would probably spend like 14 minutes arguing, or not arguing, but discussing how they would do it, and then it was too late and they didn't have anything done, right? Or they were really figuring out who's in charge, what are we truly trying to do, I want to be polite, I want to look like I'm dumb. Where the kids just got together and started working at it. And they would do, fail, push, talk, very clear commands, but they really communicated in a very effective way. They had a common purpose, and there was no questions of them feeling unsafe. Because they're kids, they were just playing. And consistently, what they would do is outperform the other teams. So really, it makes you think about the individual characteristics of the team members is not that important. But what's really important is how the team communicates amongst each other. Another great study from Google, which is the Aristotle project, they studied 180 teams, took thousands or maybe millions of data points, and were really trying to figure out what predicts our most successful teams. They tested all sorts of different ideas, like they thought, okay, well, if all the people come from certain types of schools, will that team be better? If they have a specific type of mix in terms of their personality, will that team be better? If they are very social outside of work, will that team be better? But they looked at literally thousands of data points. They spent a lot of resources in trying to figure this out. And at the end, what they really figured out is that there was one thing that clearly outperformed every other factor. And that was group norms that made the team feel psychologically safe. And if you think about the kids, it makes sense. If all you're doing is playing with 3 other kids, you usually feel pretty safe. You're going to say whatever you want to do, right? I mean, I want to try this, I want to try that. They felt very safe sharing their ideas and coming up with ways of trying to build that tower, which I think is not true if you are thrown in a group of, let's say, 3 other MBAs from different schools or from their same school. Nobody wants to look stupid. You want to make sure you're in charge. You don't feel safe to really say what you think or really give an opinion. So that was very, very interesting. And other things that were noted are dependability, which is just in terms of, when you say you're going to do something, do you do it? Structure and clarity in terms of what are the roles and what we're trying to achieve. And then meaning and impact that really tie into purpose. But for this particular talk, what I want you to take home really is the number 1, and I'll give you some tips in the last 4 minutes about how you can go back to your ICU or your ED and immediately start having an impact on your team. So clearly the title of this talk was T is greater than I plus I plus I. So the team is definitely greater than the sum of the individual components. And today we talk about team IQ, team intelligence, and that can be measured. And that is different than individual IQs. So you have very, very smart people in a team that actually has a very, very low team IQ. And that's something that you can actually work at and try to improve. So it's okay to be a superstar, but if you really want to be a superstar, you have to be a superstar with a team. And this is a concept that I really like that Sean Anker has proposed, which is by yourself, at best, you have small potential. With a team that works with you and is very successful, you have big potential. And I think healthcare, with its complexities, demands big potential. And we We'll talk a little bit more with the fellows tomorrow about more about teams, but I think that's a very, very clear understanding. I think we would all agree. So what can you do today or tomorrow when you get back to your clinical role? And again, I just want to focus on psychological safety, because I think that that's the most important thing that you can do as a team leader, which you all are, and as also a team member. And I'll share with you 6 things that I think are very, very important. Number 1 is to over-communicate your listening. When somebody's talking to you, you should really put your phone away. You should really repeat what they're saying, really listen, and not wait to give them their opinion, but listen and try to understand what they're saying and how it might change their way of thinking. So make sure that you are fully present when somebody's telling you something important. Overdo your thank yous. We talked about airways today, so a difficult intubation cannot happen without a team. When was the last time in the middle of the night that you actually thanked the radiology tech because he noticed that the x-ray was not very good and went by himself and took another x-ray, right? They're part of the team. Overdo your thank yous. There is plenty of people that you can thank genuinely for how they contribute to the team, and that will make them feel part of the team. Third is make sure everybody has a voice. When I round, at the end of the day, a lot of times I will have to make a decision. I understand that. But everybody should have a voice. If you're in a small team meeting, you never finish the meeting until everybody speaks, right? So really make sure that everybody can feel that they have an opinion. You might disagree with the opinion, or that might not be what you do at the end, but everybody on the team should have an opinion and seek for opinions. If somebody's quiet, bring them in and ask them, the RT, the nurse, whoever's on rounds with you, the resident, what do you think? What would you do, if you had to make that decision? I think that it's important to understand that trust comes from a sense of belonging. And belonging is felt when you feel safe. So making sure that you make them feel part of that team. And the second part that I think is very important, again, has to do with vulnerability. And good team cooperation comes from repeated times of vulnerability. I think that the most important thing that a leader can be is vulnerable. And the most important thing that you can say is, I really don't know what the answer is, or I really screwed up, I'm sorry. Does anybody have a better idea? And that's something that nobody likes to do, but the more you do, the more the team members will be thinking the same way. If I'm the attending, or if I'm the head of the team, and it's okay for me to admit that I'm wrong, it's okay for everybody to admit they're wrong. The point is to try to help each other to be better. So make sure that you're vulnerable and that you're vulnerable first. Admit when you have a mistake, or if you're running a code and you have no clue what else to do, feel free to ask, hey guys, I really don't know what else we can do. Anybody have any thoughts, right? And really make people feel that you don't have all the answers. Over-communicate your expectations. That's very important in terms of there's certain things that we expect from our team members. We should repeat them over and over again so people are very, very clear in terms of what as a team we have as a norm and an expectation. And finally, there's a lot of these idea of candor generating practices, which is really just after activities, reviews, or debriefing. We always do it when things go really bad. But what if we had a great intubation? Why not review what happened? What did we do well? What could we do better next time? And I think it's a great way also of keep identifying what are things that the team can do to improve. So in conclusion, I do think that there's plenty of evidence that teams are more valuable than individuals. I think that as we learn more about what makes teams better, I think it's not about our individual knowledge or how smart we are, how good we are with doing procedures. Is about how we interact with others and how safe we feel to communicate amongst each other and try different things. That's very, very important. And finally, I think that there's a lot of things that you can do in terms of making your teams better. But the first thing I would recommend is that you go back, thank people who are doing a good job, make sure that you're vulnerable and can recognize when you have a mistake, but really make other people in the team feel comfortable and that they can contribute. And I'll stop there and take any comments or questions. Thank you very much.
Any questions? Well, thank you.
Okay, lunch.
So I just wanted to take this moment now to thank all of our speakers who have taken time out of their day to put on what I think is our best conference yet. I also want to take the time to thank all of you who've taken time out of your day to come and make yourselves better and learn new things so that you can take better care of your patients and take better care of each other. Because what we do is a very, very important job every day, and sometimes you go in, you go out, and you just say, you know, it's just a job. But just think about what we do on a daily basis and how many lives you touch, and what you do is very, very special. And so I hope that this conference helped to solidify that, and maybe you made a friend or two that you can keep in touch with. But I did want to take time to thank you all for coming out. So give yourself and the faculty a big round of applause. Announcements of this will be live streamed. This is being live streamed today, but you'll get copies of the recordings at some point. If you want CME for this conference, you're like, hey, I should get some CME. I sat through the whole day. Well, just email me and we'll get you hooked up with that. And finally, if you're part of the workshops, just come on front. I'll give you instructions on what to do next. And if you're faculty and you're still here, come on down. For everyone else, get home safely, and thank you so much for coming.